Everybody, I welcome you all to this conference organized by Bihar Orthopaedic Association titled Hip Preservation Techniques and Advancements. So this topic has been chosen very carefully by our President, Dr. Ranjit Singh, and uh, this is a relatively new subject. It has come into general orthopedic conscience only in last 1 or 2 decades. Knee preservation has been around for quite some time, but hip preservation is still a nascent field. And in fact, when I was requesting people to join for this conference, I had a tough time explaining what hip preservation is. And some people had doubts whether we are going to talk about Perthes disease and DDH alone, or some people even thought that we will be discussing hip replacement, bone preserving hip replacements like ASR or Birmingham hip and all. And some even thought that I have a few cases, I can present it there. So I had to really explain it to them how relevant this topic is, since growing with this improvement in medical care, we are seeing a lot of septic sequelae, much more than Perthes disease, much more than any other probably hip condition, especially in this part of the country. Patients who have had some amount of NICU stay, and often they present late with septic sequelae, with a dislocated femoral head. Sometimes the head is absent, and we are really at a loss how to best manage these conditions. We all know relatively well how to manage a Perthes disease case or a SCFE case, but many of them are presenting very late to us. Many of them have failed their primary treatment, and then we are at a loss again how to approach this case, whether we can do anything to optimize the function of the hip, preserve the or longevity of the hip. And coming to adolescent age group, many of them develop FAI, like yesterday's case, which we used for our live surgery case. The patient hardly had any complaints, but when we examined, he had a terminal restriction of internal rotation and a pain. And he had just a minimal discomfort and inability to sit cross-legged. So there are a multitude of presentations which we are not aware of, and since we are not aware how to recognize those conditions, we hardly know how to treat them. And then again, after this COVID era, we are facing a deluge of avian cases which are probably being picked up in the right time, but we hardly know anything more than how to approach beyond maybe core decompression or fibula grafting and certain old concepts. So certain new things have come up in that field which we would like to share here. So with this introduction, I would introduce our, I would request Bihar Orthopaedic Association President to come on the dais. Dr. Ranjit Singh sir, it's his idea and brainchild. So good faculty who have travelled from far off parts of the country. First is Dr. Manoj Padman sir. He has come all the way from Delhi. He is the most renowned and knowledgeable pediatric orthopedic surgeon in North India. He is the director of Center for Pediatric Orthopedics and Disabilities at New Delhi, and he is the head of Pediatric Orthopedic Department at Rainbow Children's Hospital, New Delhi, and Fortis Memorial Research Institute, Gurgaon. I request our BOS Secretary sir, Mahesh Prasad sir, to please come on the dais, and the convener of this conference, Dr. Rajiv Anand sir. So to continue with his introduction, Dr. Manoj has done his basic medical training and post-graduation from prestigious Jawaharlal Institute of Postgraduate Medical Education and Research in Pondicherry. He then went on to the UK for his FRCS and then did his fellowship in pediatric orthopedics at Sheffield Children's Hospital, UK. And he has multiple publications to his credit and has been a faculty in our conferences quite a few times here, and people have always appreciated his clarity of thoughts and his ability to explain a topic in the most succinct and elegant way. I welcome Dr. Manoj sir. Please come on the dais. Memento. Our second faculty is Dr. Venkat Das. He is the head of pediatric orthopedics at Ganga Hospital, Coimbatore. He has done his hip preservation fellowship at Reddy Children's Hospital at San Diego, USA. He is a member of the executive committee of POSI and an associate editor of Indian Journal of Orthopedics. He has numerous publications and book chapters to his credit. I welcome, sir. Please come on the dais. Our third faculty is Dr. Prasad Gaurineni. He is a professor of orthopedics at University of Illinois, Chicago. He heads the orthopedic department at Amara Hospital, Tirupati, besides being an honorary consultant at Bird Hospital, Tirupati, and Nizam Institute of Medical Sciences, Hyderabad. He has done his fellowship in pediatric ortho from Texas Scottish Rite Hospital and has trained under Dr. Reinhard Gans in Switzerland. He is the founder of Hip Preservation Society, which is a dedicated body of intellectuals focusing on hip preservation in the United States. And he has numerous publications and books to his credit. I welcome you, sir, on the dais. Our fourth faculty is our own Dr. John Mukhopadhyay, sir. Sir needs no introduction to this gathering here, or any part of the world actually. He is a towering figure in India and abroad in the field of trauma and orthopedics. And he has done his medical education at JIPMER, and he remains a guide and mentor to most of us here. He devotes a large part of his work in teaching through the Orthopedic Research and Education Foundation and through multiple offline and online classes. I am sure he will be sharing his amazing work today in front of all of us. Please, sir, please come to that. I request our President, Dr. Ranjit sir, to say a few words.
Good morning. I welcome all the dignitaries already described and introduced to you by Dr. Saurabh Chaudhary. This program came to my mind while working in PMCs during outdoor rush. So many young patients used to come. X-ray used to, okay, it's looks abnormal, but what is abnormal? We are unable to comprehend. And then 10, 15 years back, so many literature and things, even Campbell introduced a new chapter, FAI, where we could know, well, this was the thing which we missed. And to make everybody aware of it, after having a lot of discussion with Dr. Saurabh Chaudhary, this idea occurred that we should have a conference on this subject, which is very important for the people to understand, working in peripheries and everywhere, where so many patients come with vague problems, and we just simply, okay, it's okay, looks normal, it just answers and go away. So this should not, and ultimately this ends up in later stage of life, arthritis, where we call it primary osteoarthritis, used to call it. So just to make people know this thing, and then we started having this already told by Dr. Chaudhary, when failed cases, Tom Smith, what to do, delayed presenting cases of fractured neck femur in children, where lying loose epiphysis, what to do. So have an idea what is new, how to address all these problems. This was the concept, and here we are. So I won't take much of your time. So thank you. I think by the end of the day, everybody of us will be enlightened and more knowledgeable. Thank you.
I request our Secretary of Bihar Orthopaedic Association, Dr. Mahesh Prasad sir, to say a few words.
Our respected guest faculty, Dr. Gorareri, Dr. Manoj Padman, and Dr. Venkatesh Das, and our own faculty, Dr. John Mukhopadhyay, Honorable President, Bihar Orthopaedic Association, Dr. Ajit Singh, and our past secretary, Dr. Rajiv Anand, and all the delegate who's are witness of today CME. On behalf of Bihar Orthopaedic Association, I welcome you all on this special CME. This topic is really a very new topic for me also. And at my PG days, this topic are not discussed at all. But today, we are very curious to know our most world-class faculty on this topic. And we know the fact, what is the treatment, how to diagnose it, and how to manage it. So it is a great opportunity to all the members and all the our especially postgraduate students who really know how to deal with that particular topic. And Bihar Orthopaedic Association is always being the part of this type of CME, and our Honorable President is always keen interest of this type of activity. So we start with the session, and we really enjoy this topic. Thank you very much.
Much further ado, we'll go for the lamp lighting ceremony and start the session. Please join us down the.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
लाल चढ़ायो अच्छा गजमुख को चोंदिल लाल विराजे सुत
Is behind the idea of hip preservation. It will deal with anatomy, radiology, how to read X-ray, and how to make out what is the radiological parameters, how to define the normal hip or what is abnormal. And this is a very interesting session, and this is going to be the foundational session for the next sessions to come. Second session will be devoted to surgical techniques, whatever has evolved in last few decades, and that enables us to do a lot more things which were not possible earlier. Third session is devoted to hip problems of the very young, mainly sequelae of Perthes disease and septic sequelae. And the fourth session is dealing with adolescent and young adult hip problems. So the first session is to be chaired by Dr. Vinod Kumar Thakur sir. Please come on the dais. And Dr. Madhusudan sir. And Dr. Ranjit Singh sir.
Request to come Dr. Venkat Das to give his lecture on anatomy, please.
Good morning, respected chairpersons, other faculty members and delegates. I would like to thank the organizing team for inviting me here today. And Saurabh wanted me to do a pre-test before starting the session for the anatomy. So I have planned to run the pre-test through Mentimeter. So people who are having an iPhone can please scan this QR code, and so this is going to be interactive pre-test where you are expected to vote for the questions. It will be multiple choice questions. So I request all of you to take your mobile phones out. Android users can log into menti.com and key in the number 51093619. So, and give me a thumbs up so that we'll know how many have logged in. Yeah. Four. Put the number. It's quicker and easier.
On your browser, just type menti.com.
Right? I'll go on to the first question. So you can just type in here. Where are you from? Good, good. Just type and submit your responses. Okay, so it's good to know that it's working. The second question, if you look at the screen, the question would have changed by now automatically. If it has not changed, just press the refresh button. Right. All good? Are we ready to go? If any of you are facing any difficulty, please let me know. So we have a mixed audience today. Right. So let's go on to the questions now. The first question is, which of the following artery supplies majority of the head of the femur? We have got 7 responses. I am waiting for a few more. (11, 13, 14). Okay. All done. I am going to show the results now. So majority of the audience have chosen medial circumflex femoral artery, and there are few people who have chosen the other options. Let's move on to the next question. Which of the following muscle protects the medial circumflex femoral artery from stretching while doing a safe surgical dislocation procedure? Yeah? Okay. So there's a mixed response divided between all the 4. We will see the answers as we go along the talk. I'll go to the next question. Okay, so we have got about 20 plus responses, and it is divided between ligamentum teres and ligament of Whitebrae, and few have chosen Bigelow's ligament and zona orbicularis as well. I'll go on to the next question. Which of the following group of retinacular vessels should be preserved during osteochondroplasty procedure? All right. Again, majority have chosen for posterior and superior, and the second is anterior and superior. I'll go to the last question of the pre-test now. The lateral femoral cutaneous nerve usually courses within the fascia of which of the following muscles? I think most of you have voted already for 22, 23. I'll show the results. Again, it's majority have chosen sartorius, the second is tensor fascia lata. Okay, so with this we'll move on to the talk now, and let us navigate through what we have seen. And in this talk I'll be covering about the anatomy relevant to hip preservation procedures, primarily safe surgical dislocation, and touch upon PAO as well. So safe surgical dislocation is an approach to the hip joint which is done usually in the lateral position, and the approach is from the lateral side. So once you open the skin and the subcutaneous tissue, what you see first is the deep fascia with the iliotibial band. And once you open the iliotibial band in the Gibson's interval, which is on the anterior border of the gluteus maximus muscle, what you see next will be this bursa of the over the greater trochanter. So this is the trochanteric bursa, this is the gluteus medius, and this will be the head end of the patient, and this is the foot end of the patient. Once you open the bursa, then you will be able to see the superficial conjoint tendon, which is formed by the gluteus medius here, vastus lateralis. This shining structure is the vastus lateralis tendon, and you will be able to see the insertion of gluteus maximus as well posteriorly if you retract enough. So the next step, the other structures which we need to identify are the short external rotators, which is the piriformis posteriorly. So if you retract the gluteus medius anteriorly, and you will be able to dissect the fat there, you will be able to identify the piriformis tendon. And the interval which we usually develop is the interval between the piriformis, and underneath the gluteus medius you will have the gluteus minimus muscle. You will be able to see in the next slide here. So this is the piriformis tendon, and this is the gluteus minimus muscle, and that is the interval which we develop usually to raise the external retinacular flap. So this is a cadaveric specimen to show the muscles and its relationship with the trochanter. So this is actually the right side of the right hip of the patient. This is the greater trochanter you have, the gluteus medius inserting here, and vastus lateralis, which forms the superficial conjoint tendon. And here you have the short external rotators muscles. This is the piriformis here, and this is the obturator internus along with the superior and inferior gemelli muscle, which is also called as the triceps coxae. And then you have the quadratus femoris. Obturator externus will be underneath the triceps coxae. If you cut and retract it, you will be able to see the obturator externus, and that is the sciatic nerve. So as we saw, majority of the audience voted that the head's blood supply to the femoral head comes mainly from the medial circumflex femoral artery. The artery originates from the deep branch of the femoral artery anteriorly, and then it courses posteriorly to supply from the back. So the artery starts in between iliopsoas and the pectineus muscle from the deep branch of the femoral artery here anteriorly, and this is the cadaveric specimen showing the origin of medial circumflex femoral artery between the iliopsoas and the pectineus muscle, and as you can see, it goes behind the neck. So the artery actually courses along with the obturator externus muscle. So if you see the obturator externus muscle, it starts anteriorly around the obturator foramen, and then the muscle goes behind the neck of the femur and gets inserted on the posterior aspect of the greater trochanter. So the medial circumflex femoral artery actually courses along the inferior border of the obturator externus muscle from the front, goes to the back, and then supplies the head from the behind, from the back side. So this is the same picture from the back. You can see the artery comes from the femoral deep branch of the femoral artery, courses along the inferior border of the obturator externus, and then goes into the femoral head. And before going there, it gives some branches. This is a constant branch, which is the inferior retinacular artery, which is seen arising before it goes to the intertrochanteric area. And this is the cadaveric specimen showing the inferior retinacular artery, the medial circumflex femoral artery, the inferior retinacular artery, and it passes through what is called the inferior ligament of Whitebread. So this is a ligament of Whitebread through which the vessels pass to the femoral head. Before going on to the head, it actually crosses over the obturator externus muscle. As I told you before, the obturator externus lies behind the triceps coxae. So it crosses over the obturator externus muscle. I'll show the cadaveric specimen for a better understanding. So this is the obturator externus. The artery crosses over the obturator externus and passes underneath the triceps coxae. So when you're trying to dislocate the hip, actually as long as the obturator externus muscle is intact, you will not be stretching the vessel with undue force. So this is actually called as the seat belt of the hip joint, which protects the medial circumflex femoral artery, the obturator externus muscle. After crossing the obturator externus, it passes below the triceps coxae, which is nothing but the obturator internus along with the gemelli, and it enters the hip joint into the capsule of the hip joint between the piriformis and the superior gemellus muscle. So this is the point where it enters the hip joint. Again, a cadaveric specimen showing the dissection, the medial circumflex femoral artery crossing over the obturator externus and going below the deep conjoint tendon or the triceps coxae, and here at this point it will enter into the hip joint, capsule of the hip joint, and it goes through the retinaculum to supply the femoral head. So usually the superior retinacular artery gives about 4 to 5 retinacular vessels. So this is yet another study which I found in literature where they have dissected about 28 hips, and they have located the location of the retinacular vessels. As you can see, the superior retinacular vessel extends from the 1 o'clock position up to 10 o'clock position, but if you take the main supply comes from up to 10 to 12 o'clock. So that is a supply of the retinacular superior retinacular vessels. Inferior retinacular vessels is between 6 and 7, and anterior retinacular vessel, which gives a minimal supply, is between 3 and 4 o'clock. And this is a famous experiment which was done by Sevitt and Thompson many years ago to show the contribution of various retinacular vessels to this circulation of the head of the femur. And as you can see, so even if the femur is completely intact, the neck of femur is completely intact, just the superior and inferior retinaculum is cut, the head becomes completely avascular. Whereas here just the superior retinaculum is intact, the entire neck of femur is completely cut, and the head remains completely vascular. So this is just to show that the main blood supply to the femoral head and significant blood supply comes from the superior and the posterior retinacular vessels. Let's move on to the next part about the periacetabular osteotomy. Usually it is done through the anterior approach, which is the modification of Smith-Peterson approach. And this is a very familiar approach for most of you who are doing adult work. And the first structure which we encounter will be the sartorius, and laterally is the tensor fasciae lata. The lateral cutaneous nerve of the femur runs usually into the fascia of the sartorius. So it is a good idea to open the fascia of the tensor fasciae lata without even exposing the nerve. You retract the sartorius medially along with the nerve, and that is the interval, superficial interval, go between the tensor fasciae lata and sartorius. The next structure you will see will be the rectus femoris direct head, which is arising from the anterior inferior iliac spine. So once you identify the rectus femoris, the next step is to go medial to the rectus, and you develop the interval between the rectus femoris and the iliopsoas muscle. So that is the plane which we go inside. Once you identify the iliopsoas muscle, you retract the iliopsoas, and posteriorly you will be able to see the iliopectineal bursa here over the capsule, and this actually is the lighthouse for this entire approach. From the iliopectineal bursa, if you dissect medially, you will be able to reach the superior pubic rami. You will reach the iliopectineal eminence, and you go medial to it to reach the superior pubic rami for your pubic cut. And if you go inferiorly along the bursa down, you will be able to reach the ischium, go to the infracotyloid area, and you can make the ischial cut from the front itself. So that is in short about the surgical anatomy. Do you want a post-test, or can we go to the next talk as we are running short of time? Post-test? Saurabh?
We'll go ahead with the next talk, sir.
Next talk.
Yes.
Great.
Our next speaker is Dr. Prasad Gaurinene, and he will be enlightening us on radiology of the hip.
Good morning, everybody. Thank you for coming on a Sunday. You may be wondering what he's going to tell me about radiology of a hip. I'm not going to tell you about tumors or fractures, right? We're not going to talk about Jude views and all that. We're going to talk about a plain AP view, what we should look for when you're trying to diagnose hip pain. Hip preservation, right? Non-union repairs, right? Little bumpectomies, videos, most of you do. You're already doing hip preservation. We just want to show you maybe things you're not aware of yet, right? You can expand into in a safe manner. Start with the pre-test also. So I'm not going to have like a quiz. I'm not that technically good like Venkat Das. So it's going to be vocal, right? We're all small gathering. So what's the most important image of a hip? One of the PGs. What do you think?
Anyone?
AP view, lateral view,
AP
AP
view,
view
sir.
the whole pelvis or just the hip, focused
AP.
hip? Pardon?
AP view, sir.
Of the hip or the pelvis?
Pelvis.
Why pelvis? Because you can't tell how the acetabulum is oriented in the pelvis on a standard AP hip X-ray. You need a full pelvis X-ray with good quality looking at the walls. So here, I'm showing an X-ray here. Red is anterior wall, blue is posterior wall. So what do you think is wrong with the acetabulum? Quickly. The red line is anterior wall, blue line is posterior wall. It's pretty normal or is it really abnormal? Which is abnormal, what do you call it? What type of hip is it? Pardon? No, both are pretty similar, right? Both have anterior wall way lateral to the posterior wall. There's posterior deficiency, anterior over coverage, that's classical retroverted acetabulum, right? It's an inlet view, but ignore the inlet view for right now. Try to understand what I'm trying to show, a retroverted acetabulum. Forget the right side, which is a SCFE. What's on the left side? Is that left side normal, abnormal, and what's wrong? We're going to come back to this X-ray after my talk, right? Anybody saw anything like this? So anybody can tell why, if this patient has pain in the hip, why is she having pain? Is it because, he. Is it because the neck is too long? Why will a long neck hurt?
Coxa vera.
Coxa vera, why will that hurt? Yes, coxa vera is correct, but why will that cause pain? So focus on what his head is doing. Is his head really loading the social? Look at the space on the top. That head is not actually pushing on the social at all. It's pushing way medially where there is no articular cartilage. That's called foveal impingement. The head is pushing against the ligamentum teres and the acetabular fossa, which does not have any cartilage. So these are the things we need to look at on an X-ray in addition to coxa vera and long neck, right? All right. So like we all discussed, AP view of the pelvis is the most important X-ray. It has to be a good AP view, right, where you center the beam so that you can see both hips adequately without any too much tilt, any obliquity, or any rotation, all right? So in adequacy, rotation-wise, you should look at the sacral line, mid-sacral line going to the symphysis pubis, so no rotation. The obturator foramina should be symmetrical on both sides, right? For obliquity, one side shouldn't be higher than the other, the iliac crest, but that's easy to adjust. You rotate the film around and you'll be able to adjust obliquity, but rotation will be very hard to adjust. Then tilt of the pelvis. Most pelvises are tilted anteriorly, right, 30 to 45 degrees, but if the X-ray is too tilted, the obturator foramina will be too small. If it's outlet view, the foramina will be too big. All these things will change how you interpret the acetabular morphology. The femoral head may not change much in the views, but the acetabular morphology will change. When you look at a retroverted acetabulum like I showed you earlier, a normal X-ray, normal person, you get an inlet view, they all look retroverted. You get an outlet view, they all look antiverted. So you need to have a proper X-ray to interpret what you see on the acetabular side. And then the bone outline should be visible. You should be able to see the walls. The anterior wall and posterior wall should be visible on your X-ray. Otherwise, you have to repeat the X-ray. So with that introduction, this particular X-ray, the rotation seems to be okay, right? The mid-sacral line going to symphysis. The foramina a little smaller, little bit of inlet view. The junction from the sacrococcygeal junction, from this part to this part, a little increased. Ideally should be about 2 to 3 centimeters. More than that, it's an inlet view. So keep that in mind when you interpret. Thank you. All right, rotation is good. Foramina a little smaller, but reasonably okay. So reasonably good X-ray. This one is obviously not good. One side much higher than the other and rotated. Look at the foramina, asymmetric. So what this does is the right hip will look more antiverted. The left hip will look more retroverted than it is, right, with the rotation. A big foramina, not much distance between the coccygeal junction and the symphysis. Outlet view. This outlet view will make the hip look antiverted, the acetabulum antiverted. The anterior coverage will look falsely decreased, while the posterior coverage looks increased, right? Bigger inlet view, the foramina very small. So this will make the acetabulum look retroverted, though it's not, right? An inlet view. So certain things like pathological, always pathological problems are, if you have a cyst, a lesion, a growth, outgrowth, fracture, or loose bodies, they're always abnormal, right? You know how to reinterpret those and you know how to treat those conditions. But there is an ideal morphology I'm going to describe that's not very common. If I take X-rays of all of you, I think 50% will have some abnormality. So you have to correlate the abnormality to the clinical presentation and symptoms. So the top ones are always abnormal, but certain variations I'm going to describe are abnormal only if they're symptomatic and the exam correlates with it. They're not always pathological. They're not pathological always. They're variants. So variations are very common. And then the variation can actually be additive, compound one each other and cause pathology, or can compensate for each other. For example, if somebody has coxa valga and acetabulum is overcovered, they're compensating each other. But coxa valga and acetabular dysplasia make each other worse, more symptomatic. So we need to understand those before we treat. You look at an X-ray and say coxa valga and don't do a varus osteotomy if somebody doesn't have instability, right? So on the acetabulum, it's not very complicated. There are only 3 structures: sourcil on the top, anterior wall, and posterior wall. And then all 3 have 3 variables: size, shape, and inclination, right? So here's an X-ray. I drew the central axis of the neck where we look at the coverage, right? Just the central axis of the neck, the yellow line. You all know this iliopectineal line doesn't have a whole lot of importance, in my opinion, in hip preservation. We don't look at this too much. But this is ilioischial line. We call it Kohler's line. In hip preservation, we look at this. We want the hip center to be within 5 to 10 millimeters, not hip center, the head to be within 5 millimeters from this Kohler's line. Less than that is more medial, and more than that is more lateral. Lateral is unstable. Medial is probably a risk factor for impingement. They'll have less range of motion. That's the sourcil. The sclerotic weight-bearing dome of the acetabulum is the sourcil. I didn't draw this all the way to this corner because that corner does not have sclerotic bone. It's extra-articular. So that makes a difference in how big the angle you're going to measure. That will give a difference of 3 to 4 degrees. And that may decide you're going to operate or not operate, right? So it's important to know where the sourceal ends. The sclerosis, wherever it ends, this is the sourceal end. So that's the sourceal. This sourceal is concave on a convex head, perfect, right? It looks big enough, so it's not dysplastic, but there are ways to measure this. And look at the sourceal to the weight-bearing axis relationship. It's perfect on this X-ray because this line is coming at a 10-degree angle to the midline. The sourceal is very perpendicular to it. The sourceal is upsloping. The weight-bearing force is going to subluxate the head laterally. The sourceal is negative. The head may migrate medially. It's called medial instability. Not a common thing you learn about, but I showed you that X-ray of the coxa vara. That's medial instability. The head is migrating medially and pushing against the ligamentum teres and the acetabular fossa, right? That's the anterior wall. How do you know it's the anterior wall? The anterior wall is more horizontal. Let me show the posterior wall too. That's the posterior wall. So posterior wall goes to the ischium, more vertical, right, and almost straight. The anterior wall has a curvy, an S shape to it. This is the psoas gutter that gives the shape, right, and it goes to the pubis. So the anterior wall should not cross the posterior wall in a good epipelvis X-ray. If it crosses, it's always abnormal, does not mean it's pathological, does not mean you're going to operate, but it's an abnormal finding. The anterior wall should not cross the posterior wall. The anterior wall should be medial to the posterior wall, and they both should meet at the top. In the cross, we call it crossover sign. So crossover sign is abnormal finding, a variation, not pathological always, right? And the other thing to make important is these crossover signs and other things are just more subjective. They're not objective in the terms of how much coverage. A little crossover sign, a big crossover sign. Some people call it an index as to where it crosses. Even that's not important. What's important is you learn how much of the head is covered with the anterior wall at the center axis, right? This posterior wall should cover 50% of the head, right to the middle. If it's medial to that, it's deficient. If it's lateral to that, it's over coverage, right? That's called posterior wall sign if it's deficient, but it does not quantify how much deficiency you have. So what I'd recommend is, look at, is it 50% perfect? Is it 40%, 30%? Then that helps you with treating up the hip. You're not going to do an operation with 45% coverage deficiency, where you're going to do an operation with 30% right, coverage. Same thing in the anterior wall. The anterior wall should cover about 15 to 20% of the head. Less than that is dysplasia, and more than that is over coverage, right? So right at the center. Even that's not perfect because you can have good coverage here and deficiency on the top. So you need to measure other ways also to see how much coverage there is on the top. I'll show you a different way. So that's the teardrop. In general, a narrow teardrop is healthy, but it's very narrow or it's reversed. That's a deep socket. The teardrop is very wide. That's dysplasia, but that's not diagnostic. That's just a clue. The diagnosis comes from you measuring the percentage coverage of the head to say whether it's deep or not. So don't go by indirect signs, go by direct measurements to really be accurate. Same pelvis, vertical line to the center of the head, right? We're measuring objective numbers now. That's the LCE, lateral central angle of Weiberg. This is very commonly used for lateral dysplasia. 25 to 40 is healthy, it's a range. Less than 25, probably dysplastic. Less than 20 is definitely very dysplastic, right? No question. But 25 to probably 20 is probably borderline dysplasia. You look at other parameters to see if it's unstable or not. More than 40 is over coverage. It's a variation, but not pathological always, right? But here, a less commonly used number, medial central angle. You need to have enough coverage medially also. If you don't have enough medial coverage, then you can have medial osteoarthritis. It sees you, 10% of total hips are done for medial osteoarthritis. The problem with medial osteoarthritis is not diagnosed correctly because the superior space looks wide, not arthritic, but there'll be bone on bone rubbing on the medial side. So you look for medial coverage also. Total arc should be about 50 to 60, so you want 25 on either side. So a good acetabulum will have about 25 degrees this side and 25 degrees this side, minimum. Here's an example of how you don't have much medial coverage and they can subluxate medially and start developing medial osteoarthritis. This is a young person with pain, does not have arthritis yet, but this is a reverse sourcial angle, negative, right, negative, and the head is migrating medially, unstable, and causing medial rubbing. LCE is very good, but upsloping source, reverse sloping sourcial. So on dysplasia, inlet view again, not a perfect X-ray, but it's okay to see. This is the inferior part of the neck, the blue line. That's the pubis. That's the Shunton's line, broken. That's a sign of subluxation. It's not diagnostic again, but a very good clue to say that the head is probably subluxated. That's the transverse line of the pelvis. That's the acetabular index. You're looking at the slope of the acetabulum. I showed you in the previous one the negative slope. This one is upsloping. Normal is 0 to 10 degrees of upslope. 0 to 13 upslope is normal. More than that is dysplasia laterally. Negative sourcial angle is more medial dysplasia and medial subluxation. Is that clear enough? You guys are following? I mentioned the LCE again. Very narrow LCE. I told you about less than 25 is dysplasia. This is almost like 5 degrees. Very dysplastic. Right? So these hips become bad really fast. When you diagnose somebody with dysplasia, don't ask them to come back in 6 months or 1 year. I've seen them destroy their hips in less than a year. So if you don't do the operation yourself, send them to somebody quickly before they get arthritic. So ideally acetabulum, the roof should be 80% coverage, that LCE on the top, right? You don't need to measure the LCE every time. You look at the roof, the sourcial should cover 80% of the head. Posterior wall 50%, anterior wall 20%. Less than that is under coverage, more than that is over coverage, right? Version 15-20% anterior. Sourcial should be about at least 50 to 60 degrees. Sourcial angle 0 to 10 is ideal, and then sourcial shape should be concave on a convex head, right? So with that, ideal is right in the middle. Left will be dysplasia, right will be impingement. But unfortunately, you may have one on the dysplasia side and the other on the impingement side, and both can coexist. We have a separate talk to discuss the complex between the two. So with over coverage and under coverage, right, of anterior wall, posterior wall, you can have 9 types of acetabular, and 4 of them will have crossover sign. So don't answer in the exam that crossover sign means retroversion. I don't know. Your exam, you can answer whatever your professor tells you, but practically, crossover sign can be seen in 4 other types of acetabular. I'll give you some examples. You can have anterior over coverage and posterior deficiency. That's true retroversion. A retroward acetabulum is turned backwards, anterior over covered, posterior deficient. The correct operation for that is to anterior the acetabulum. You can have anterior over coverage, but the posterior wall is normal, has a crossover sign. Turning the acetabulum is not correct there because the posterior wall is already perfect. So you remove the excess bone in the front. Anterior rim trimming is the treatment for that, right? Makes sense. A lot of noddings, good. You can have anterior and posterior both over covered, and still can have a crossover sign because the anterior wall is covered more than the posterior wall. That's a deep acetabulum like a protrusio. There, you remove the rim of the acetabulum all around or anteriorly to correct the impingement. You can have dysplasia on both front and back and still have a crossover sign. That's not true retroversion. Some people call it retroversion. There you have dysplasia globally with more anterior coverage than posterior coverage, so you need to do a PAO. In children, you can have a false crossover sign. In pediatric patients, you can have false crossover sign because the posterior wall is not fully ossified, so they may look like they're overcovered in the front because the posterior wall is not fully ossified. Here's an example of anterior over coverage, more than 15% coverage. He has both over covered, but there's a crossover sign, right? This is almost like a protrusio. Here I'm showing an example of AIIS prominence, subspine prominence. The AIIS should not be this prominent. Here there's an avulsion fracture, here there's none, but both are prominent. That's a risk factor for AIIS impingement. So start paying attention to the shape of the AIIS. If it's overhanging like that, it can decrease the flexion range. The femoral neck may be hitting that area and squeezing tissues in between and cause impingement. So AIAS is prominent here. On the femoral side, you have an ideally spherical head, but it's not perfectly spherical, but reasonably spherical. Start looking at the physeal line. Even in adults, you can see the physeal scar for the shape of the epiphysis. Look at the fovea, where the fovea is. Fovea is where there is no articular cartilage, there's a defect, right? And then look at the head-neck offset. Is the neck narrow enough to have good range of motion, or the neck too thick, right? There are ways to measure that. Alpha angle is one way, I'll show you how to measure. And then the neck shaft angle by itself does not mean a lot, but coxa valga will have more range of motion. Coxa vera will have less range of motion and impinge. Coxa valga is more like dysplasia. Coxa vera is more like impingement risk factor. And the neck length. Ideal neck length should be one head diameter between the center of the head to the tip of the trochanter. Anything longer than that is coxa longa. Anything shorter is coxa breva. Coxa breva is a risk factor of impingement, less range of motion. Coxa longa is a risk factor for femoral neck fractures and trochanteric bursitis and pain, prominent trochanter. And then GT and LT should be noted too. A prominent GT can impinge and a prominent LT can impinge. So again, about 10 to 20 degree anteversion, normal neck shaft angle, normal head to neck relationship, up to 12 degrees of posterior tilt of the head on the neck on the lateral view are considered ideal. Anything more than that is impingement, anything less than that is dysplasia. So physeal scar. This is clearly a sign that there is cam morphology. You can see the spherical head, but if you see the physeal scar going like that, that's called epiphyseal extension sign, where the epiphysis has grown onto the neck and the head is probably not round, a risk factor for cam impingement. Here is sagging rope sign. We all learned sagging rope sign as a different mechanism, as growth disturbance or something like that. It's not. It's outline of the head. We see a big sagging rope sign, that means the head has grown onto the neck, cam morphology. The tip of the trochanter should be at the center of the head. If it's higher, it's coxa vera. It's lower, it's coxa valga. Sourceal again, weight-bearing axis, epiphyseal extension sign. So a round head, the bone that's going out of the roundness, right, where the point it's going out is called alpha point. That's where the sphericity is starting. If you draw a line from there to the center and the neck axis, the angle between the two is called alpha angle. The smaller the alpha angle is, less than 50 or 45, the more range of motion it will have. The bigger the alpha angle is, more than 55, 60, it's a risk factor of impingement. They won't have as much range of motion. Patient yesterday has impingement, right? He has both over coverage and increased alpha angle. Few more examples. Perfectly round head, but the epiphysis has grown onto the neck like this, so there'll be a bump in the front. The cam will be right in the front where you cannot see it on APR lateral views. You need a 45-degree done lateral like the doctor said yesterday. Again, another example of epiphyseal extension sign. No offset, right? Straight line. And the groove there is called impingement groove, where the rim is impinging onto the neck. Here's convexity from the impingement, not a scaphie. All these are important if the patient has pain. Not at all important if the patient is asymptomatic, but become important when they have pain. Not sure what I'm trying to show you here. Yes, again, established index. That's the healthy contact with the head and the neck. Head and the acetabulum, the sourceal. That's the fovea. The fovea should be inferior to the sourceal. If the fovea is too close, it's going to be unhealthy, the contact between the acetabulum and the femoral head. So that's the sourceal to foveal angle, should be at least 10 degrees. Here is an example of caput valgum. This head is into valgus. That's the healthy cartilage contact, very small, because the fovea is against the sourceal. Healthy head is outside, not contacting. Retroverted acetabulum. Okay, let's go back to this. The quiz, right? Finishing up the quiz. Anterior wall is way over covered. Posterior wall is very deficient. Retroverted acetabulum. the ideal treatment is anti-verting PAO, right? If you remove the front wall here, you make them deficient front and in the back deficiency cannot be corrected afterwards because you made the anterior wall more normal. Anybody want to tell me now the same X-ray from before? Is that coxa vera or coxa valga? Though the lesser trochanter is visible, this is the most varus angle the patient has, right? Almost straight. More importantly, not only coxa valga, head is also in valgus compared to the neck, laterally tilted, called caput valgum. Coxa valga, caput valgum, and head is not covered fully, mild dysplasia. So all these put together are a high risk for dysplasia in this patient, lateral subluxation. So if you open the capsule in this patient, you're going to make them really worse. So do not open the capsule unless you're ready to correct the bony deformities in a hip like this. And this hip should be sent to somebody who knows how to do, not somebody who knows. You can do it too. Varus osteotomy is what you need for this patient. A big varus. But that varus can cause abductor weakness, so you need to be prepared to transfer the trochanter if necessary. We'll talk about all this in later talks. So again, medial subluxation. The head is not even touching the source The pain is because the ligament teres is getting crushed between the head and the medial acetabular fossa. And this neck is at risk for stress fractures, but more importantly, this head is migrating medially. So the correction will be a valgus osteotomy to bring the head out and touch and contacting the source seal properly. Not difficult. You all can do valgus osteotomy. If you recognize this, that will be the right answer. Thank you.
Any questions? Okay. I think everybody understood the radiology very well. Sir, just to re-emphasize, how do we exactly quantify caput valgum and varum, and what implication does it have?
So, caput valgum is valgus of the head on the neck, right? You can have coxa vera and caput valgum. So you should look at them independently. The neck axis to the physeal line should be ideally perfect, perpendicular. Anything tilting laterally is caput valgum. Anything displacing medially is caput verum, which is your scaphi, varus scaphi. Right? Anything posterior is a posterior slip. Anything going anteriorly is an anterior slip. So that relation between neck and head also is important separately, not just the neck shaft angle.
Dr. Manoj Padman. He will be speaking on distorted morphology of and its clinico-radiological correlation.
Good morning, everyone. So I think I'm a frequent visitor to Patna now. And it's good to see old friends, and so I thank the Bihar Orthopaedic Association office bearers and Saurabh for inviting me over. So this entire topic can sometimes be very daunting and intimidating, and don't feel too bad about it. When we first started listening to some of these concepts, some of these when I first heard the radiology slide, and sometimes it can just go fly over your head, But what we are hoping at the end of the day is to expose you to these concepts and start looking at these things, okay, as a first step, as a prelude, not to kind of, shut your mind to it, because this is evidence, this is well-established guidelines now in practice, and certainly hip preservation has a big role in our country, not necessarily so much in primary FAI, how the West is practicing. But lots of our pathologies have these same concepts, and if you can kind of learn these concepts and use them in your practice, it will help. So don't shut your mind to it. This is no doubt there will be a lot of information. There can be a lot of information overload. Don't think that we are advocating you to kind of look at x-rays and diagnose pathology in every x-rays and start treating them. Because in the absence of clinical symptoms, as Prasad alluded to, these are just morphological variations and no more than that. So my talk is just to kind of say, okay, we see these X-rays, what does it mean? And, can we kind of make some link with clinical correlation? Because ultimately, at the end of the day, the X-rays are a pointer to a natural history. So if you see a dysplastic hip, you don't have to wait until the symptoms come, because you know that's a car crash happening in slow motion. At some point, it's going to wear out. So whereas other other findings have to be taken in the context of clinical findings. So when you are looking at clinically evaluating, you need to first establish that hip joint is the source of pain. Because you could have a mixed bag, you could have back pain, buttock pain, neurologic pain and all that. So that's the first thing, So you need to, we will cover through some of this, and probably in the last session in femoroacetabular impingement, you'll get a clearer concept of that. Most of it, we are talking only about, mechanical pain. We're not talking about inflammatory pain, arthritic pain, neurologic pain and things like that. So you need to establish that. And as far as possible, try and identify the source of pain, which is why the medial impingement matters, because you have huge varus and you do not know why is the hip paining, because it's the ligamentum teres getting squeezed there. And so you have an anatomic source of pain there. So this is how you want to kind of approach this. So non-mechanical pain have certain features, which are pain throughout the arc of motion, rest pain, night pain, pain associated with constitutional symptoms or with other joint pains. That's clearly this thing. So we are not talking about any of these pathologies. Mechanical pain can be either with movement or with just position as well, and they usually worse with activities. The positional changes can be depending on what an individual does in day-to-day life, whether it can be twisting, sitting up from a low car, all of these things. So all of these things are. So you need to be sure that that the pain arising from movement or a change of position, that's mechanical. So I'm not going to go through a detailed clinical evaluation in that sense. So history is important. Most of the hip pain here, we're looking at, classically they'll come and tell you that, they hold their hand like a C. But it can be anywhere. It can be anterior, lateral, posterior. It can be in other locations. You need to try and identify what's a pattern, what is the frequency, triggering factors, and during an examination, are you able to reproduce the symptoms? So when you then you are reasonably sure that the pain is coming from the hip and it's mechanical in nature, you need to try and see, what is the cause of it? Is it something which is, is it an intra-articular problem because of all these reasons? Or is it an extra-articular problem? Or is it a combined this thing, because impingement can be both intra and extra-articular. So you need to kind of try and see, as you kind of start thinking about this, at least you kind of say, okay, this is coming from within the joint or outside the joint. Another way of this thing, these are what works for you and what you are able to kind of identify with, what you're comfortable with. You can look at what is the source of pain. Again, there's a lot of information here in terms of, it is not that difficult. Is it coming from pure osseous pain? Is it a capsular pain? Sometimes it's not easy to distinguish, but at least you should be able to eliminate neurological pain, neurovascular pain, or pure musculotendinous pain and things like that. But that's another way of trying to identify where the source of pain is. In terms of examination, again, I'm not going to go through a detailed examination. You need to do it in all positions, but I'm just going to kind of just briefly allude to a few simple things which you have to kind of do routinely and in a reproducible manner. Standing, obviously, you need to look at all these things: gait, foot progression, stride length, rotation. There's a lot of information that you can get with just simple stance and walking. You also need to complete your rest of your examination as well. Just because it's all hip, you don't miss out on other things. These don't take too much time. It's just, probably half a minute for all of this, a quick neurological examination, a spine examination, and whether there is hypermobility. And supine examination, there is the classical hip examination, which all of you, I'm pretty sure, are familiar with, so I'm not going to go through that. Range of motion is important, and you will see this being repeated throughout this thing. Flexion to 90 degrees, and internal rotation and external rotation. As a simple, if you want to look at one single movement, and I'm not saying that this is the thing to look at, but start looking at this value. What is the internal rotation in 90-degree flexion, that is FIR, and what is the external rotation at 90-degree flexion? Because a lot of our treatment in terms of FIR of 0 degree means that that's inadequate, and usually if there is reproducible pain, when you are trying to internally rotate more at 90 degrees, that's a sign of anterior impingement. So FIR and FER are two important movements that you need to kind of start looking at. Apart from your routine, complete comprehensive clinical examination. So now, that's just a brief overview. So when you have something like this where it's kind of clearly obvious that there is a pathology there, you may not be able to pinpoint each of the symptoms as to what is the exact radiological correlation there. But clearly you can see there are a lot of abnormalities. The patient may come with all kinds of symptoms related to that. They may come with just a gait abnormality, a fatigue pain because of trochanter overgrowth and abductor insufficiency. Variable degrees of range of movement, because it's well-adjusted children, sometimes they say, oh, I'm able to do everything well. Or they may say some specific functional limitation, I'm not able to sit cross-legged. And you might think, what is the reason? With the trochanter high riding like that and impinging on the iliac blade there, you cannot rotate. That apart from whatever else may be happening in the joint, the trochanteric impingement may stop the external rotation. So you can correlate some of these radiological parameters to clinical findings, and they can have secondary symptoms. So here, it's not so difficult correlating radiological findings with the clinical picture. So again, a quick overview about this thing. So I'm not going to go into as much detail as Prasad's this thing on radiology. If there is one area that at the end of the day, if you say, oh, there's so much information, if you can go back, getting material to look at in terms of radiological evaluation on AP pelvis, that will be a good starting point, So you need to kind of be familiar with all the concepts that Prasad alluded to. So specific to this case, you can see trochanteric overgrowth and abductor insufficiency. That's caused fatigue pain. Coxa is there, even though the neck shaft angle is not too bad. Clearly coxa breva, short neck, so you have to start using these concepts and using these terminology, because all of these need to be addressed if you're going to kind of correct it. So it's not just a question, oh, there is coxa and I'll do a valgus osteotomy. That's not the be-all and end-all for this. Acetabular dysplasia is there. You can see the shunt trans disrupted, more so on the left, and definitely impingement, and depending on how severely affected, there will be lingering discrepancy. So you can kind of correlate some of the clinical symptoms with the radiological findings. The difficulty is when you see something like this. This is one of my patients, which we recently operated. Prasad and I did it together on this one. There's an 18-year-old who was a late presenting DDH, came at around 6 to 7 years of age. That was when it was picked up. I did the primary surgery. It's one of my patients. Open adduction, femoral and pelvic. Ended up having residual dysplasia. Has been on regular follow-up. His level of functionality, this is X-rays, I think, when he was probably about 16 or 17. When we advised surgery. At that time, he was playing badminton at the district level, 4 to 5 hours of badminton every day, functioning at that level and not bothered by it, despite being advised that this would require. We first, I think, advised surgery probably in 2017, okay, because you can see clearly findings there, okay, but the patient does not have enough symptoms. So this is the case wherein you have dysplasia, because it is just a matter of time he's going to have arthritis. He already has signs of it. He's still able to function at that level, but this is one area where you will have to kind of rely more on radiological findings. You can't say, oh, patient is asymptomatic, I'll wait, because before you know, it'll become frankly arthritic, and then there's nothing else you can do. That hip will not be salvageable. So here, radiological, this thing takes precedence over in dysplastic scenarios. Okay, so that's him. The only clinical examination that we could find consistently was, he had some deformity which disappeared under anesthesia, but he had decreased FIR and FER. That is the only reliable clinical examination with reproducible pain, with discomfort when you pushed beyond that internal rotation. So very minimal clinical symptoms in the presence of very strong radiological findings. You cannot, I've sat through meetings when people say, oh, the patient is asymptomatic, patient's asymptomatic, patient's asymptomatic. So this is something where you will have to kind of intervene early. So he has acetabular dysplasia. The sourcil, you can see, is very steep. Coxa vara, the trochanter is high riding. Normally the tip of the trochanter should be somewhere near the center of the femoral head. Trochanter is higher, the fatigue pain can be there. Coxa breva, to some extent. You can see the sagging rope sign, which is not a sign of any physeal irregularity, which essentially means the head is aspherical. If you take an orthogonal view, you will see the large head. And clearly he has arthritic changes, early arthritic changes. So if you kind of shut your mind to hip preservation, the only option is wait for the inevitable arthritis and do hip replacement. That's unacceptable. Okay, so you take a functional view to see how well the hip is congruent, no big change. You want to see whether it's going to sit in. That's to decide management, but I'm just telling you about preliminary evaluation. So you really need, this is not a frog view, this is an abduction internal rotation view. This is the orthogonal view. You can see lateral view. You can see on the picture on the right, which is you can see this is what you see as a large cam. That's the normal side. That's how it should be. This is what you see from the front as the sagging rope sign, the large cam morphology. Okay, you can see that's a normal anterior central edge angle. I think the lateral central angle is covered. This is a false profile view. This is not a lateral profile view. You can see that this is all negative. It's gone the other way. So there's a huge deficiency there. So there's a lot of information there in the absence of very little clinical symptoms. So I conclude with another case, a 14-year-old, no previous history, a 2-year history of relatively vague, not very active, relatively sedentary child, but noticeable enough for the parents to bring the child for consultation, review. Initially, I think 2 years ago, the first consultation was actually teleconsultation. It was that significant during COVID, they felt the need for a teleconsultation. Activity-related discomfort, and parents are saying that the limb tended to go a little bit into external rotation. And again, you can see that the sentence is already disrupted here. You have caput valgum here, dysplasia, both deficiency of both anterior and posterior wall. Again, not something to say, okay, relatively low symptoms, ignore, let's wait and watch. This is again, a car crash going to happen in slow motion, yeah, at some point. So you can't just be an innocent bystander to this. So these are the findings that you see. So the functional view, you see that it's seated better so that you can plan your treatment. On the false profile view, you can see that there is not much deficiency on the anterior central angle. So that's how you kind of try to interpret. So what I have tried to kind of try and piece together, some pushing the ball further from what was Prasad's talk about radiology to bring in clinical context, and then I think this is followed by the instability dysplasia concept. So my remit was to kind of tell you that if a child presents with or adult for that matter, presents with hip pain, establish that it is actually hip pain and it's mechanical in nature, standard radiological evaluation, we've not talked about MRI or CT and plain X-rays interpretation, you work on it. Try and correlate the morphological findings that you're seeing on the X-ray with some of the clinical symptoms so that you can plan your treatment to address the morphological findings, and that should do well for your patient. Thank you.
Thank you, Dr. Padman. This was the thing which has spurred me to think of this conclave, where patient used to come with minor symptoms, the morphology was distorted. We were not aware.
So what is this sagging rope sign which corresponds to your?
So I think sagging rope is what we first kind of learned from Perthes disease, and we thought that it is some sort of a physeal kind of. Now if you have a spherical femoral head which is deformed with a large cam, with a large bump on the front, when you look at it on an AP view, you're not able to see the bump in profile. If you take a lateral view, you will see that. That overhang of the misshapen anterior femoral head, when you look at it on an AP view, you see it as the outline as you see as a sagging rope. So it's not a physeal scar, it's not the physis, it's not a sign of any growth disturbance. It's a sign of a large anterior deformed femoral head, what we call the cam morphology. Can be posterior, but largely.
You can see two of them, front and back. Right?
Our next speaker again is Dr. Prasad Gaurinene, and will.
Both of you explained very well regarding the X-ray only up till now, because whenever we used to go to any conference, we were always told MRI, MRI, and MRI. Luckily, both of you stick to X-ray, and there are so many things to see in X-ray only. What ultimately, does it matter if you don't go for an MRI, you plan an operation? Because the cartilage must have distorted, degenerated, and everything. So will your plan for operation depend on your X-ray finding only, or will you go for MRI? Because if you have done an operation, most of the things you may have missed, and is there any chance of a medico-legal complication also?
Great question. I always get an MRI before I operate on for FAI today. I was not doing it before in America because I did a study and found that it's not useful. People are now doing studies and saying that MRI is not useful, but it's a good way in India especially to get an MRI because first it's not expensive, there's no radiation. Second thing is, it's much more common to have less obvious AVN and bone marrow edema syndrome in India than I've ever seen in America. I get MRI, clear FAI, and then they come with big edema in the head. I just wait for a few months for that to settle down before I do it. So MRI is good. Rule out other pathology tool. If I get a normal MRI, then I focus on the mechanical problems because MRI rules out all the non-mechanical causes of pain, right? CT scan, I rarely get it, but CT scan is useful too if you don't understand the X-ray morphology. Till you understand seeing the X-rays properly, get a CT scan to look at where the cam is if you want to. The reason I don't get it is because I can see it on X-ray, I have experience now, plus intraoperatively I'm going to look at it anyway. So I'm prepared to deal with it wherever it is, but if you're not prepared to deal the entire morphology right away, you get whatever test you need. But MRI is good for FAI, not for dysplasia. I don't think you need to get an MRI scan in a 14 or 15-year-old for dysplasia. I don't think either of our patients he showed, we got an MRI pre-op. Because the MRI is not that good in telling you how bad the cartilage damage is, right? MRI may say good cartilage and I'll find defects. MRI say bad cartilage and I'll still see it pretty good. So it won't change what I do in terms of cartilage quality. But AVN tumors to 127 neck shaft angle, is that the right thing? Or do we need to balance out with whatever we see on the other side, the established side? Do we correct everything to perfectly normal? That will be a lot of surgery, right? Do we understand whether it's what's abnormal completely and correct every tilt, version, shape of everything? Are we capable of doing that? I don't know. Or do we correct only the obvious cause? Somebody hip pain, you see neck shaft angle coxavera, I'm going to bring it back to 127. Is that the right answer? Are you going to overtreat or undertreat, right? And lastly, when you do an operation, you don't want to cause a secondary problem. So prevent a new problem from arising. For example, again, a coxavera, you do valgus osteotomy, the hip may start subluxating now because they have probably a little dysplasia that you missed, right? So that led me to think about how to optimize the hip, right? It's not hip preservation as much, you want to optimize hip function. So you want to restore all aspects of hip function with the least intervention, right? You agree? You don't want to operate unnecessarily. You don't want to do too many surgery, too many procedures. Maximize the durability of the hip. They're young people, you're trying to save the hip. A 1 year or 6 month relief is not enough. We want to give as long as we can. Without visible deformity. It's okay to have coxavera. I have patients with neck shaft angle of 100 degrees post-op after finish, but they don't have any obvious deformity and that's okay. Obviously, pelvis is too wide on one side when you do a varus osteotomy. Things like that probably should be avoided, very obvious cosmetic deformities. But luckily the hip is deep, so there are not too many cosmetic problems with the hip correction. And without compromising future reconstruction. Keep in mind that none of the procedures I do are going to save the hip for the rest of their life. I'm postponing the eventual hip arthroplasty. So you total hip arthroplasty surgeons can feel very safe, right? You'll be in business, you'll have your total hips, but postpone this from 14-year-old maybe to 30 or 40 years of age. And my goal is not to make your job harder, right? I don't want to create secondary deformities you can't deal with or too difficult to deal with. And lately we are thinking that we're going to remove all hardware within a year after our surgery to make sure that you don't need to deal with it afterwards, right? That's hip optimization in my opinion. So hip function depends on the morphology mostly, the bony morphology of the femur and the acetabulum. But you've seen Manoj's case where the acetabulum is very dysplastic, less than 50% covered, but the hip is functioning well. That means the ligaments are holding it. So in that situation, if you cut the ligaments even a little bit, you're going to exacerbate the condition. So if you're going to do any arthrotomy in a dysplastic hip, you need to be prepared to correct the bony deformity or prevent instabilities. Then each person is different. Why is that kid at 18 functioning so well with so much dysplasia and arthritis? And some people with little bumps can't function and come with a lot of pain. It's biological resistance to pain and arthritis, right? And if people are active, obviously they're going to get more symptoms. So how to analyze hip function? Going back to the first question I asked you. Is it pain-free and limp-free? If they're walking, is that good function? Or is it sitting, squatting, running, jumping? Then how much? How fast, right? And then how much motion in which direction? We talk about FIR, flexion, internal rotation, external rotation. How much is we want, right? Each person may have different needs. And then do we look at neck shaft angles, alpha angles and LCE alone, right? So these are making things complicated for me. So what I came up with over years is morphology dictates function, so I want to end up with balanced morphology of the bones. I'm not going to rely on soft tissues, right? I don't want to leave the operating room thinking that, okay, it's a little dysplasia, but hopefully the capsule will hold it. That's not ideal. You can't rely on soft tissue. They may not, right? And the variations are common. You need to figure out which are contributing to the instability or this impingement, with the clinical diagnosis impingement, and which are compensating for it. You can identify those things. You won't correct compensating deformities, and you will definitely correct contributing deformities. So treat the ones that cause dysfunction or have established poor prognosis, right? A spherical head will always impinge. So anyone with a bump on the head is not going to have good motion. We know that. So if they have pain, you're going to make the head spherical. Anyone with subluxation, with dysplasia, are going to get arthritis. That's a given. So you don't want dysplasia with subluxation not treated, right? Here's an example. A young person, 30s, female, somebody missed it at this point. Within like a year, look at the state progression. Once symptoms start, the hip can go really bad fast. Dysplasia of subluxation. A bump like this, 26-year-old, SCFI, already joint space narrowing. You won't have good function. Somebody protrusio. 50% of protrusios get arthritis by the time they're 40. You may say, how come the right side did not? That's why there's biological and activity level and a few other parameters that compensate. Maybe antiversion is compensating, something is helping on the right side, but left obviously, end-stage arthritis. So some of these things are very obvious. So what are the other things that correlate with the different things, right? So I grouped hip problems into 4 categories. One is cartilage, right? Weight-bearing cartilage, instability, impingement, and abductor dysfunction. These are the 4 categories where all hip dysfunction can be put into. And what are the causes for this? In the cartilage category, you have osteochondritis dissecans, the fovea being too high, loose fragments, articular step-offs, articular gaps from malunions, right? Things like that can be cartilage problems. Instability, acetabular dysplasia, coxa valga, caput valgum, increased anteversion or increased retroversion can cause instability in different directions. Impingement, coxa vera is a risk factor impingement. Coxa breva brings the trochanter down, there is no neck, so they'll have impingement. Coxa plana, it's a flat head, will impinge, won't have good motion. Profunda, a deep acetabulum, will have decreased motion. Prominent AIIS, like I showed you in that example, will have decreased flexion. Prominent GT can impinge in all directions. Hopefully they'll cover in our FAI talk, but GT can impinge in the front, laterally. The gear shift phenomenon you get in abduction, GT impinging on the lateral side. GT can actually impinge on the sciatic nerve in the back, compress the sciatic nerve in external rotation. A normal looking GT can do that, right? And LT, right, prominent LT can squish the muscles between the ischium and the LT and cause pain, called LT impingement. And then for abductor dysfunction, you have coxa vera, breva, which will alter the abductor liver arm and the resting length, and increased anteversion or retroversion can also cause abductor dysfunction. So with this, we're calling the 4 essential things for a hip. Good cartilage in the weight-bearing area, stable head in the socket, impingement-free motion of that particular hip in that patient, right, is different for each person, and good muscle control. If you can ensure that you can have all these 4 at the end of your operation, your treatment, that hip is going to do well. They'll be able to run, jump, and do all these things, right? So these are the minimum requirements for good hip function in everybody. Even without these, you may be able to get away with something, but if you ensure that you get all these 4, that hip is going to do well. So what does these 4 pillars tell you? They'll try to give you a clinical significance of what you see on X-ray, right? They'll help you avoid unwanted consequences of your treatment, right? For example, coxa vera of neck shaft angle of 100 degrees. Say somebody came with 100-degree neck shaft angle. If they have no problems, no symptoms, obviously you're not going to treat them. You don't care about 100-degree neck shaft angle as long as there are no symptoms, right? You don't need to correct. If they're calling medial loading like the case I showed you, you definitely want to do a valgus osteotomy for it, right? To the extent, not to 127, to the extent you bring the head out onto the source seal. 127 may not bring it out to the source seal, right? You want to match the head to the source seal. So whatever a valgus is required to match that head to the source seal, you need to bring it out. If the coxa vera and have established dysplasia and it's preventing lateral subluxation, you don't want to correct that coxa vera because that's actually supporting your hip, keeping it in place. You do valgus osteotomy saying, oh, he has hip pain. You're going to ignore that mild dysplasia and do valgus osteotomy. That's going to subluxate more, right? And if they're impinging, and the coxa vera is causing impingement, obviously you can do either valgus osteotomy or some type of relative neck lengthening to correct that impingement problem in the neck. And lastly, if there's abductor weakness, right, you can do either valgus or relative neck lengthening to optimize the abductor function. So with the same neck shaft angle 100, if you use these four pillars, you'll be able to figure out what the correct treatment would be. And we're not looking at making it 127 in everybody. It will be different for different people. So Manoj already covered diagnosing hip pain. I'm going to skip this. He showed you a FIR, how to check for internal rotation, how to check for external rotation, right, clinical exam. But again, radiology we covered at length. So treatment options now. Think about the philosophy a little bit. Again, I mentioned this already. Do you want to correct all variations of normal limits, right? Can you really figure out all these perfectly? And can you correct all these? And will that not be a big, big operation? Trying to correct everything, right? Or some people say, I'm going to make it look exactly like the opposite side. How do you know the opposite side is perfect? Do you have a measurement of every parameter on the opposite side, and won't that be over-treatment? If you say, I'm going to correct only the most likely cause, maybe that's under-treatment. But if you use these four principles saying that I'm going to leave the operating room with all four functions restored, I think you won't over-treat or under-treat. So preservation principles, a few principles. Inability to have good cartilage on the top of the head is a contraindicator for preservation. If there's no good cartilage on the top, there's no preservation, right? If there's no good cartilage now, if you can rotate it in a way that you can bring good cartilage, you can do that. But you need to end up with good cartilage on the top of the head. That's minimum. You don't need to have established cartilage because you can put fascia on that side. That seems to work. But on the head side, you can't put anything biological if there's no cartilage. And correlate variation to dysfunction and figure out which ones to correct how much, not to make a normal neck shaft angle. Correct to balance the hip, right? And then you treat them based on the risk-benefit analysis in your setting, right? So when to go to the pelvis? Some people say, established dysplasia, I can do varus osteotomy to compensate. But a varus osteotomy will make the leg shorter, abductors are weaker, and the hip will become prominent. And men don't like a wider pelvis on one side, especially. Nobody likes abdominal anatomy, but men definitely won't like a wider pelvis. So that's a problem if you treat established dysplasia with varus osteotomy. If there are version problems in the acetabulum, you can compensate with varus version osteotomies in the femur, but is it really the correct way? The pathology in the acetabulum, do you want to do it in the femur or acetabulum? Overcoverage, you can correct some overcoverage in the acetabulum with valgus osteotomy, but the problem is on the acetabulum, so you decide, is it less risky for you to do on the femoral side or on the acetabular side? The acetabular side is just rim trimming, simple reshaping. And it's a negative social angle, you can compensate. Anybody know what they're seeing here? So I told Saurabh that every talk we're going to go back to X-ray again and again. Because by the end of the day, whether you learn to do any procedure or not, I want you to be able to diagnose things. So any of the juniors, what do you see on that X-ray? What's abnormal? Quickly. We don't have that much time. So little coxa vera, higher, but right, medial impingement. See that? Everybody's seeing medial impingement now. Very good. Right, medial impingement. The head is subluxed medial because the social angle is negative. Look at the joint space is healthy on top. So if you look at only the top, you'll say, well, it's good joint space. I don't know what you have. Take some medication and just live with it. But there's bone on bone rubbing on the medial side, right? That will cause medial osteoarthritis on both sides. So this is not something you can treat with any femoral procedure other than cutting the head off. This has to be an acetabular correction if you're going to do anything. That's the sourceal angle. You can expect how the head will slide medially and not load the sourceal. So coxa vera, we saw an example, and this is acetabular side pathology that's causing medial loading. So when to do both? When you cannot get away with one side, you need to operate on both sides, the acetabular and the femoral side, right? And that's pretty common sense. And if you fix one side, it may unmask the other, then you have to correct both, right? And overcorrection of one is not tolerated. We'll skip this, you decide. So when do you do femur first? You do femoral deformity, if the femoral deformity is so bad that you cannot do acetabular correction, you want to correct the femur first. All right, they want me to end this talk here. A new X-ray, look at the tip of the trochanter. If it's high, it's polycoxa vera. If it's low, it's coxa valga. Right? So
Can
here,
we comment that this is a true AP view?
no, it's an inlet view, not a good AP view.
Yeah.
It's an AP view, but yeah, very good point. Bad AP view. But here, if I'm looking at impingement, this is definitely not acceptable. For dysplasia, subluxation, I have the information I need, so I don't need to repeat the X-ray in this particular situation.
This
Right?
type of X-ray many times you see in post-polio residual deformity also.
She does have polio. You're correct. Left side polio. We're seeing more and more polio people coming with hip pain from the mild dysplasia. When I was in training 30, 40 years ago, they said polios don't get any problem, leave them alone. But polios are coming with arthritis and hip pain now.
Is it a loose bodies there?
Probably it's outside extra-articular,
Outside
quite
extra-articular.
calcified labrum versus capsular calcification avulsion. So anyway, applying those four elements here, from this to this, what do you think we did? One of the India's most prominent hip preservation surgeon looked at it and said, see, I told you valgus osteotomy, you should do valgus osteotomy. That's what you did. Did I do valgus osteotomy there? What did I do? And? Yes? That's it? You know what? I did 30 to 40 degrees of varus. Right? Because if I don't do varus, that hip won't be stable. So I need that varus to compensate for the acetabular dysplasia. So what I did was I wanted varus to compensate for the acetabular dysplasia here in this particular patient because I know that I need to get the abductors more functional. So RNL plus varus. Avoided the acetabular osteotomy, sticking to the principles of don't do too much, minimum surgery. Yeah, optimization at the end. So rotation should be last. You don't figure out the rotation till you correct your varus, get everything, and then say, okay, fine tune the rotation at the end. What do you guys see here? Aspherical head, septic sequela, one of the rare septic sequelae I've seen in America. I've seen only 2 or 3 in about 20 years. Coxa breva, coxa vera, high. Acetabular dysplasia, severe, right? Subluxation. So you need stability, you need to clear GT impingement, you need to abductor function, right? Putting all the 4 principles again. You want neck length, head to be round, so you know that you're going to take this bump off. You want the neck longer, so you can do RNL. Trochanter has to come down. Plus, once you open things, the hip is going to dislocate completely because of dysplasia. You need a PAO. That's your plan. That's what is done, right? I didn't do any osteotomies down below. Relative neck lengthening is a simple thing to recover from for the patient. I'm going to have a talk on it. So acetabular osteotomy, relative neck lengthening, and little bumpectomy in the bottom. Here's that fovea alta patient I showed you. Ligament teres is getting crushed in this patient. That's what's causing pain. The treatment was RNL plus varus, like I showed in the previous case. The fovea is now not touching the sourceal, so we corrected foveal impingement and gave a lot of neck length. All right. Thank you very much.
Thank you, sir. Question? Okay.
You bring trochanter down.
Yes.
How?
So you basically, 2 ways, a simple trochanteric transfer, cut the trochanter and bring it down, but that won't clear all that remaining bone that's still on there.
Yeah.
So there's a talk on relative neck lengthening.
Okay.
Stick to it, we'll talk about it.
Thank you.
Right? Thanks.
we have a very absorbing session. And any question from the audience or any of the subjects covered? One more topic.
I think
Hip dysplasia, instability, and impingement complex.
all right. good.
Again, Dr. Prasad coordinated.
A lot of repetitions. I think it's good to get the ideas right confirmed again and again, reinforced. Can I have? There you go. So this is a newer talk I had to prepare for this particular thing because Saurabh came up with this hip dysplasia instability impingement complex. All right, new term for me, but I'll try to explain what I understand by it. So definition of these three terms. Dysplasia is a radiographic deficiency, usually of the acetabulum. Dysplasia just means that the acetabulum is not deep enough, right? Instability can be static or dynamic subluxation of the hip. Instability is a tendency for the head to be unstable in the socket. Dysplasia is a risk factor, but does not mean that dysplastic hips are unstable. Instability can be there even without acetabular dysplasia, right? Head that's coming out for various reasons. FAI, other guys have two talks on FAI, but my definition of FAI is impingement is abnormal stresses in a hip from normal movements of abnormal bones. The bones are abnormal, and the movement of those abnormal bones is causing stress and pain in the hip. That's what impingement is. All types of impingement fall into this definition. So dysplasia, it describes hip morphology that predisposes the femoral head to instability. It does not mean that a dysplastic hip is unstable. If you see subluxation, then that's definitely unstable. You want to treat it. But dysplasia is a radiographic finding of deficiency of the acetabulum. So shallow acetabulum, inadequate head coverage, upsloping or short sourcil, weight-bearing area will be smaller. You can even have down-sloping sourcil like I showed you before, where you can have medial instability, right? Coxa valga, caput valgum, add to lateral instability. Coxa vera adds to medial instability. Increased anteversion, anterior instability. Retroversion, posterior instability. Things have to be balanced, right? So dysplasia means there's abnormal morphology that predisposes a hip to instability. Does not mean it's unstable yet. So treatment of dysplasia is, if they don't have instability, right? In a growing child, dysplasia can get worse if you wait, so we don't wait for symptoms. In a growing child with dysplasia that's not getting better with whatever you're doing non-operatively, I think surgery is a good idea in a growing child. No symptoms. You don't wait for any pain or limp in a child. Dysplasia subluxation is a good reason to intervene at any age. Dysplasia subluxation is known to do worse. In a growing child, things will get worse much faster. In adolescent and adults, the subtle symptoms that start at the time can progress really fast, like I showed you in that case, right? Then symptomatic dysplasia, obviously somebody coming with symptoms and have dysplasia, you're going to treat them. Instability, either this frank, obvious subluxation or a subluxatory stress on the head. You can't see the subluxation, but you can imagine or get an MRI scan to see the strain on the labrum. The labrum becomes hypertrophied if the dysplasia is significant enough and the head is trying to subluxate. Muscles hypertrophy, iliocapsularis and gluteus minimus hypertrophy to stabilize the head. Ligaments get bigger. Ligament teres gets thicker, right? These are signs of compensation of subluxatory stress, right? The increased loads of a dysplastic hip, called rim syndrome. In the lateral dysplasia, the acetabular weight bearing will be more point loading at the lateral aspect and can cause acetabular rim syndrome, labral tears, and damage, arthritis. And then medial subluxation, I told you, foveal impingement is an issue. Prognosis, instability rarely improves on its own, right? I used to say never improves, but I've seen one or two cases where miraculously somebody is subluxated and refused treatment, came back, and the head went back in. But that's a rare exception. Don't wait for miracles to happen all the time, right? Treat them. And they progress to arthritis rapidly. So stabilization always requires an osteotomy. There are a few orthopedic sports doctors doing capsular plications and label repairs on borderline people, but obvious dysplasia instability, never soft tissue. It's always bony surgery on the femoral side or the established side. Impingement. Again, like I said, pain and damage in the hip from abnormal movement, normal movements of abnormal bones, right? I'm taking some of their thunder out, but the types of impingement that I deal with are intraarticular cam, pincer, mixed SCFE. Manoj is going to cover them. Extraarticular, AIS, GT, LT. Now, this complex, right? Combined, you can have dysplasia and FAI in the same hip. So cam with dysplasia is very common. Most femoral heads with dysplastic femoral heads have cam morphology. Does not mean that the cam is always symptomatic, but if you don't have good motion at the end of your PAO, better deal with the cam. Do the cam osteoplasty. Last POSNA, they said 50% of hips are getting those osteochondroplasties with PAO. My rate is much less. You can have FAI and instability, right, combined. Cam with dysplasia doesn't mean that it's always, that's more morphology. This is, FAI is a dynamic problem and instability is happening. Both are happening, right? We need to treat both. Like that case I showed that lady with polio, where the GT is up and she's dysplastic. So you need to correct both. Then you can have a concept called FAI-induced instability. FAI by itself can cause hip to be unstable. I'll show you examples. So cam with dysplasia, very commonly seen in young males. Big cam, small established. You need to figure out which one to treat, right? When you're not sure which one is more symptomatic, or if both are symptomatic, is unstable, you can treat both. But if you're not sure, it's very difficult to diagnose the cause of the pain. Is it the cam or is it the dysplasia? So clinical exam helps. The range of motion is increased, that's more likely to be instability. If the range of motion is decreased, it's more likely from cam impingement. If the X-ray shows any subluxation, instability. If the MRI shows labral hypertrophy, that's instability, right? Cam should not have labral hypertrophy. Cam will have a nice small labrum. Dysplasia will have a big, thick labrum, hypertrophy. And intraoperatively, the damage pattern also tells you whether it's cam or dysplasia. Here's a patient of mine. He had, right is pre-op for the PAO, left is post-op for the PAO. So he had both cam and established dysplasia, borderline, no subluxation. So I thought that it's cam and operated on both hips for arthroscopically cam resection. But a year later, he still had symptoms. So we did a PAO on the left side. Then a year later, he came back for the right side saying that he still has pain and the cam is corrected. So we did a PAO on the right side. So if I'm not sure, I stage them. Less invasive first and go for the more invasive later. If I'm sure about both being problem, correct both at the same time. So this is how intraoperatively I can diagnose if it's cam or not. Look at how soft that cartilage is. You see the bubbling of the cartilage? This is the labrum, right here. And this is cartilage medial to the labrum. That should not be soft. Softened cartilage is called chondromalacia, right? So this is the junction of the labrum and the cartilage, and this cartilage is bubbling here. That's a sign of cam impingement. That's classic of cam impingement. So when I see that, then I'm happy that I'm going to take care of the cam problem and not worry about instability. The labrum is not hypertrophied. But if I see this, when I do the arthroscopy, this labrum is avulsing off with a piece of cartilage. That's classic labral tear with dysplasia. When I see this, I'm very worried that that hip is actually subluxated and dislocated post-operatively, and quickly after the arthroscopy, I'm going to talk to them about doing a PAO. Okay. So if they have FAI and instability, you know both are a problem right away. They're usually complex deformities. Both can be symptomatic, and correction of one unmasks the other. So you want to correct both either at the same stage or quickly afterwards. Even I don't remember what we did here, but corrected, obviously. We did cam osteoplasty plus PAO. Here in this case, you know clearly that both are problem, right? I can't do a PAO because the GT won't allow me to do a PAO. If I cut the GT and do relative neck lengthening, that's hip is going to dislocate. So if I'm going to stage this, I have to do femur first for sure. And if for some reason I can't do the acetabulum right away, I need to be extra careful in immobilizing this patient in abduction till I can do a PAO. You see this, right? Shallow acetabulum, GT impinging, cannot do acetabulum first. But if I do the femur, the hip will become unstable. So we need to do both in the same sitting or quickly soon after. So that's we did on same sitting, RNL and PAO. Last topic, FII-induced instability. You may not believe me that most people with traumatic hip dislocation that you all deal with have some degree of impingement or a decreased internal rotation. A dysplastic acetabulum rarely dislocates after trauma. Have you any of you seen a dysplastic acetabulum? John, have you seen a dysplastic acetabulum dislocate post-trauma? Right? You think it's already dysplastic, shallow, why is it not dislocating? Because they have increased range of motion, they don't impinge, so there's nothing levering the head out. But if you pay attention to your traumatic acetabular fractures and dislocation, posterior dislocations, and check them when you do exam under anesthesia, they have decreased FIR. Cam morphology, we have a few presentations in the US, no published paper, but a lot of them have FAI risk factors, the traumatic hip dislocations. So more common than we think in traumatic dislocations, FAI plays a role, right? Anterior FAI levers the head posteriorly. Right? Hinged abduction, pardon? Probably have a fracture, just a fracture, or the femoral neck fracture, something like that, right? Narrow neck, very, right? They'll break more easily in the femoral neck, and less likely to dislocate. They'll probably hit into the wall and get posterior wall fractures more commonly. Hinged abduction is a FII-induced instability, right? You're hinging on the bump on the lateral side or the greater trochanter, and you subluxate immediately. That's instability. Counter-coup damage, I'm going to explain to you what this is. So if you have anterior impingement, see how the labrum is going to crush between the neck, the head can subluxate posteriorly. This is what traumatic dislocations happen. Normally, the capsule is so strong that it's not easy to dislocate. So you and I, impinging in the front, will not dislocate, right? But in a lot of trauma, that can lever out from the back, tearing the posterior side. That's a traumatic explanation. But here, what's happening is repetitive anterior impingement with posterior subluxation can cause damage to the posterior acetabulum called counter-coup damage. Posterior labral tear and posterior acetabular cartilage damage. Counter-coup. He's a traumatic dislocation patient. You see this sagging rope sign? That's a sign of cam morphology. He had cam. So after reducing, you can see the spherical head. And I had actually some of these patients, I go in surgically, for whatever reason, loose bodies or whatever, and I find indentations, crushes in the front of the neck, like a groove from the trauma, acute trauma. Labrum is all trashed in the front. And I have to do... Or a little fracture dislocation, not the pure acetabular fractures like you deal with. Talking about small little rim fractures, things like that. There, you can have that. So this is an example of anterior FAI. This is a patient has SCFE, posterior SCFE, and look at his posterior cartilage wear. Impinging in the front, but levering off the head in the back and rubbing off this cartilage. I have only 2 examples in my career where this counter-coup damage are documented. A little shameless plea, hip preservation education. Anyone interested further to learn these concepts, join our WhatsApp group. It's pretty active. A lot of our other faculty are on there. We discuss cases regularly. I have a website with all the radiographic analysis and a lot of these articles written. I wrote them, hippreservation.com. It's up to date in the last year or 2. Lastly, we have a hip preservation course in Tirupati, December 8 to 10. Thank you.
Sir,
yes.
Well, this counter-coup phenomena, does it happen with CAM or both?
I don't think it's specific for CAM or pincer, but that particular case I showed you is from anterior SCFE, so you can call it CAM, but it can happen with either.
Can happen with the pincer?
Yes.
Okay, thank
yes.
you. So, with this, we come to the end of this session, and all the Questions are invited from the audience. Any question, any clarification? And I request all the faculty to come onto the stage to answer those questions. Any question?
It was
Okay.
overwhelming, I think.
No question. The subject is quite absorbing and difficult, so maybe first let them learn and I think absorb the thing. Thank you.
Thank
With
you,
this, we come to the end of the session.
We'll honor the chairpersons of this session, sir. I request Rajiv Anand, sir, to please honor the chairpersons. I request Rajiv Anand, sir, to honor Vinod Thakur, sir. Honor Madhusudan, sir. अगला session बोला? Start with our next session that is focused on the surgical techniques. I request the chairpersons for this second session to come on the dais, Dr. Rakesh Chaudhary, sir, and Dr. Amuli Kumar Singh, sir. So after we have learnt about how to recognize the various morphological problems, we'll start learning the techniques how to tackle those issues.
Coming to the second session, session 2, and first is Dr. Venkat Das, sir. Yes, sir. We were talking on the safe surgical dislocation of the hip. Yes, sir.
Good morning once again. So this is primarily a technique session. So we are going to learn about how to do a safe surgical dislocation. As I told already, this is an approach to open the hip joint and which allows you to safely dislocate the hip joint without damaging the vascularity of the femoral head. As you are dislocating the hip, you have 360-degree access to the hip, both on the femoral side as well as the acetabular side. So indications, we have seen a lot of pathologies which have been discussed in the previous talk. So any pathology inside the hip joint which needs surgical intervention is an indication. FAI could be primary or secondary due to SCFE, Perthes and post-septic, about which we are going to discuss later in today's session. So these are the primary indications for safe surgical dislocation. The other relative indications are femoral head fractures. When you have a head fracture, you can fix it through surgical dislocation approach. Certain forms of acetabular wall fractures. And when you have tumors like exostosis from the neck, chondroblastoma on the head of the femur, or even osteoid osteomas, you can use this approach. And synovial chondromatosis is one another condition where if you want to remove all the loose bodies from the joint, you can do a surgical dislocation. The technique was first published in 2001, JBJS, British. It's available online. You can check out the detailed surgical technique publication. We'll go through it step by step. The patient is positioned lateral, and you should have a provision to allow to flex the hip to about 120 degrees. And it's preferable to use a THR drape, or you should have a provision to hang the limb when you dislocate it. So you should have a pouch in the front. The incision is centered over the greater trochanter. You give a liberal incision about 15 centimeters, and you can slightly curve it anteriorly. So we are dislocating anteriorly usually. And once you open the fascia, you will be able to expose the conjoint tendon. And this will be a repetition of my anatomy talk a little bit. After exposing the conjoint tendon, the next step is to do a trochanteric flip osteotomy. So we'll see the steps of how to identify the level where we do osteotomies in the video, which is coming subsequently. In general, the osteotomy should not be too thick or too thin. If you are too deep, you can hit the vessels. If it is too thin, it becomes unstable. So the ideal thickness will be about 1 to 1.5 centimeters. And there is a modification of this osteotomy, which is a Z-shaped osteotomy, which was described by Nosley, which gives a more stable fixation, which I am not familiar with. So once you do the trochanteric flip, you retract the fragment anteriorly along with the gluteus medius and vastus lateralis, and you expose the gluteus minimus and piriformis tendon, and then you will be directly on the capsule anteriorly. You have to elevate all the muscles of the capsule, which is adherent to the capsule anteriorly. It will be part of the gluteus minimus and the vastus. Once you elevate the muscles, then expose the capsule nicely. You do a Z-shaped capsulotomy to open the joint. And once the joint is open, the maneuver to dislocate the hip is flexion, adduction, and external rotation. And you do gentle rocking movements. And in certain pathologies, the ligamentum teres is weak and you will be able to snap off the hip. It just snaps off and dislocates easily. And in some cases, you have to use a curved scissor to cut the ligamentum teres to complete the dislocation process. So I'll play a small video, which is about 10 minutes, to show the dislocation, surgical dislocation technique. So that is a positioning of the patient with a pillow in between the two thighs, and you can see that the pelvic post is kept slightly proximal than the usual position for you to allow about 120 degrees of flexion of the hip. So this is the left hip of the patient. Patient is positioned right lateral. I am doing the skin incision now. This patient had acute on chronic stable slip capital femoral epiphysis. I think you saw the x-rays initially. So most of the patients which we come across are obese patients, so you have to have a liberal skin incision and then elevate the subcutaneous fat of the fascia, that is the deep fascia which you are seeing. And I use a cob elevator to elevate the fat of the fascia, and that's the deep fascia which I am opening, starting off distally. And then you go proximally. As you go proximally, identifying the interval is important. So that is a gluteus maximus muscle fibers. We have started seeing the fibers. When you see the fibers, the interval is slightly anterior to the anterior border of the gluteus maximus. So I am going anterior to the fibers there. So that's the Gibson's interval. And you release the fascia all the way up to the iliac crest so that you have enough working space to dislocate the hip joint. So once you complete this step, the muscle what you see underneath is actually the bulky muscle is the gluteus medius, and I am opening up the trochanteric bursa to expose the vastus lateralis distally, and proximally you have the insertion of the gluteus medius muscle. So at this step, as I told previously, you will be able to identify the insertion of gluteus maximus distally. That's the insertion of gluteus maximus. And the next step is to identify the piriformis tendon. So usually, if you ask your assistant to internally rotate the limb, and you can use your index finger to roll over the tendon. That is how we feel the piriformis tendon. And you ask the assistant to retract the gluteus medius muscle anteriorly and dissect there carefully to expose the piriformis tendon. So I am dissecting the fat there to expose the piriformis. That is the piriformis tendon. And we know that the vessels are inferior to the piriformis on this side. As long as you stay superior to the piriformis, you are safe. And I am developing the interval between the piriformis and the gluteus minimus muscle. So that's the superior border of piriformis, and that's the interval which we need to develop. And this step is essential when you are planning to do an extended retinacular flap. For a simple FAI surgery, you don't have to go through this identification of piriformis and developing the interval. And now the next step is to mark the points for trochanteric flip osteotomy. So you stay about 5 millimeters anterior to the posterior border of gluteus medius. So that is the landmark, so that it stays away from the insertion of piriformis. That is the proximal point. Distally we go to the axilla of the vastus lateralis, and then we connect these 2 points, and that will be my osteotomy line. And the technique to do osteotomy is you ask the assistant to internally rotate the limb, and then you use an oscillating saw to do the trochanteric flip osteotomy. In patients with severe slips, it is a good idea to use a curved osteotome to do the opposite cortex cut, otherwise you might cut into the neck. And once you do the flip osteotomy, you gently externally rotate the limb, and then you will have to cut the rest of the gluteus medius muscle, which is adherent there, to make the fragment more mobile. So I am just releasing the part of the gluteus medius, and you can see that some amount of piriformis also can be attached to the flipped fragment, which needs to be released carefully. So that is actually the part of the piriformis which is attached to the mobile fragment of the trochanter, which I am going to release now. So I am releasing the piriformis, and then once that is done, you will be able to flip the fragment anteriorly completely, and you retract it. So now we are seeing, what we are seeing here is the muscles over the capsule of the hip joints. This is part of the vastus intermedius distally, and proximally you will have the gluteus minimus muscle. So it is called as capsularis minimus. So it is important to elevate all these muscles of the capsule. So Dr. Prasad says this as a red-white dissection. The capsule will be white and shining. So and the muscles are red. You can use a Cobb elevator to elevate of all the muscles. And this is the minimus muscle which we are elevating off the capsule. So it is important that you go all the way up to the supraacetabular area for you to complete the capsulotomy. So after elevating the capsule, so as you go proximally, you may be able to identify the reflected head of the rectus femoris tendon, which usually arises from the supraacetabular region. So next step is to mark the capsulotomy. This is the horizontal limb, which is usually parallel to the neck, and that is the inferior vertical limb. And you can see once I am opening the capsule, there is blood-stained synovial fluid which is coming out, which is a hemarthrosis. It's an unstable slip here. So that completes the inferior cut, and then we go horizontal, continue with the horizontal cut till the rim of the acetabulum, and then you will be able to identify the labrum. At that point, you turn the cut to do the superior vertical cut. So I'm using an Alice forceps to hold the capsule, and I am completing the other part of the Z capsulotomy. And you can see the labrum there, and this is the bump which we are seeing now, and that is going all the way back. The capsule is released well, and now we are ready to do the dislocation maneuver. So we usually use a bone hook. You put a bone hook onto the inferior aspect of the neck, then ask your assistant to flex. So I am using a bone hook there. Flexion, adduction, and external rotation. So that is the maneuver. At this point, the ligamentum teres can hold back the complete dislocation. So I am using a curved scissor to cut the ligamentum teres there, and once it is cut, you will be able to appreciate that the head is coming out. So that completes the safe surgical dislocation procedure. Thank you.
Thank you very much. Was very interesting. We all should be knowing about this because we'll be using it many of the times, keeping the head safe. The next talk is another very important talk which we as general orthopedic surgeon are very dreaded to go in, intracapsular osteotomy on the femoral side. Though we know we want to do it, but we still try our best to avoid it because we are not very confident. So for this, we call upon Dr. Prasad to go ahead and talk about it.
So intracapsular osteotomies. Basically, you just have intraarticular osteotomies or head and neck. You don't do anything intraarticular osteotomy-wise on the established side. Right? No true cut, just trimming and small things. So it's either head osteotomy or neck osteotomy. So head osteotomies, you can do a head reduction, remove the central part of the head. You can do variations of it by removing a wedge, like anterior wedge, something like that. Or you can undercut the articular surface, remove some bone underneath it, and make the head smaller. On the neck level, you can do actually varus osteotomy for coxa valga, valgus for coxa vera. I don't do those. I'll show you variations of what I do. Rotational osteotomy like Sujioka can be done, again, around the neck. I'll show that in a different talk. I think my Sujioka talk is on like impingement, different talk. Skefi, very common to do neck osteotomies. All the deformities at the head-neck junction, so that's where you do the correction, if you can. Malunited neck fractures are similar to Skefis. Some of those subcapital malunions, again, neck osteotomy. So starting off with head, not a great X-ray, but to show you on the right side, it's coxa magna and coxa plana and coxa vera, a big head, subluxated. Typical Perthes, post-Perthes deformity. So you can plan, you can template how much of the head you're going to remove. It's not 100% accurate, but reasonable idea. So I outlined the head. Lateral segment has its own blood supply. Medial segment will have its own blood supply. So you can remove this central part without actually killing the head with this proper SSD approach. And how much you remove, you can template on a paper to get an idea. It's a two-dimensional area, but there are 3D models also. I haven't used myself. But regardless, you have to be able to modify them intraoperatively. You may see a defect that you're not expecting. The cartilage may not be as healthy in some places, so you need to be able to modify. That's the reason I don't do any 3D templating prior to doing a head reduction osteotomy. But the more preparation you do, the better in general. So here, as you see, I drew a 14 millimeter segment I'm going to remove, right, leaving the medial and lateral halves viable. So at the end, when you collapse it on the paper again, that becomes rounder, smaller and rounder. Now it's never going to perfectly fit the acetabulum, and it's not that important. No one has showed rapid destruction of the acetabular cartilage from a smaller head. So the mismatch, don't worry too much about it. I mean, you'd like it to have perfect, but if it's off a little bit, it's okay. What's important though is because of the mismatch, the hip is unstable. So you need to get the acetabulum to be more flat. You don't want even a little bit of dysplasia that risks subluxation of the head. So you want to contain the femoral head by acetabular osteotomy often with this procedure. So head reduction alone is not adequate if there's any acetabular dysplasia. And you can see how the lateral vessels supply this lateral segment, medial vessels supply the medial segment, and central part can be removed without causing AVN. A case example, a bigger head that's not fitting the acetabulum, pretty healthy cartilage overall, septic sequela. This is my second septic sequela that I saw in the US. The central segment being taken off. So you want the saw to be a finer saw, not a big thick saw that takes more than you planned, right? And you dissect out the flap, right, so that it's safe to pass the saw all the way to the back. So the central segment is being resected. I couldn't take the whole piece as a single piece, but obviously, reasonable. So luckily, this particular head matched perfectly the acetabular side. You can see the labral seal restored, and you can see the head bleeding, right, after the correction. So something like this, I showed you this earlier, coxa longa with coxa vera with all this. You want valgus and neck shortening here, right? You can do a neck osteotomy right to the neck, preserving the blood supply. You can resect and put 2 screws to hold it. But the way I do it usually is more lateral than in the neck, and do some type of modification instead of doing it right on the neck. But you can do it at the neck level also. This is what I would plan for something like this. I shorten the neck more laterally than pure neck osteotomy. But the disadvantage is I need a plate for this. More healing time, bigger hardware, more symptomatic hardware. The other one is more elegant, but may not be safe all the time. Taking such big wedges may actually compress the retinaculum. It may actually kink. Because I'm dissecting the retinaculum, then shortening everything. If it kinks, I don't know what to do at that point. That's the reason I don't try neck osteotomies for those conditions, where I cannot restore neck length up to optimal level. Here's not my case. Caput valgum, like I showed you earlier. A neck osteotomy, opening wedge neck osteotomy was done. I think it's that Sanjeev Madan series. Looks very nice, but the problem for that is, if the flap does not allow me more correction, then I'm stuck. I can't do anything else, right? And also I need a bone graft. The lines become more vertical. Your Powell angle is not great when you do an opening wedge osteotomy of the neck. However flat you start the cut, it's going to become more vertical, more medially. So healing problems can be there. So for that reason, I don't like to do neck level varus osteotomies personally, but it's doable. So it's my case I showed you before, caput valgum, more severe than the other case. Foveal impingement, that's the ligament being crushed, and I chose to do intertrochanteric intertrochanteric varus with relative neck lengthening to get the same effect. Here, I can do unlimited correction. No risk of the flap. I don't need to even dissect the flap, right? Here's my example of a done osteotomy. It doesn't look too bad here. Stable scaphy. Doesn't look terrible. Moderate scaphy, but look at the clinical deformity. This is the maximum internal rotation he has at 90 degrees of flexion. And you want 20 degrees for a healthy hip. 20 going this way. And this is minus 50. So you want 70-degree correction. So that's what you want at the end, to optimize the hip, to restore all 4 pillars. So first, Venkat showed the SSD. I'm going a little step further. Elevating the flaps around the neck. When you do a neck osteotomy, you want to develop the flaps all around. You want to peel the soft tissue as one envelope, like peeling a banana. But the banana skin is more important than the banana itself in this case. So you want to peel it very carefully. So medial flap was raised, easy. Lateral flap is a little more difficult. You piecemeal the trochanteric fragment slowly and then remove it laterally. Once you develop the flap all around, the head can be popped off the neck. That's the open physis done osteotomy, right? Then you remove the callus around the neck and not shorten it too much. Shorten it enough to preserve the blood supply, but not shorten it too much where you're going to disturb the mechanics of the hip, right? Don't create coxa breva. And then fix it, right? That's a modified done osteotomy. So this patient did quite well. That's his internal rotation afterwards, able to function well. So a done osteotomy is simpler because you go to the physeal scar, not physeal scar, physes. It's soft. You pushed on it, usually liver it, it pops off. But if you have a healed scaphy with the same deformity, it's fused, no physis to go through. It's a totally different ball game. A neck osteotomy is what you need to do through the neck cutting. So the head has to be mobilized by completely breaking the neck with a sharp tool. You have to bang it with an osteotome. I don't have the courage to use a saw in this situation, so I use an osteotome, but it's multiple, it's not a simple one whack. Careful peeling and cutting. Osteotomy through the physis should not be done. Through the same physeal scar, you're too close to the vessels with an osteotome, so don't do it a little more distal. Leave a 5 millimeter gap between the physeal scar and the osteotomy level. Then whatever metaphyseal bone you leave on the head, you can remove it separately afterwards with the burr, right? And you need stronger fixation because it's going to take longer to heal. It's more of a bony contact than a facial area which heals faster. An example, pretty bad SCFE. You don't have any room between the head and the GT, right? 90 degrees backwards. All the other osteotomies you do more distally cannot correct this very well, right? It's too much of a deformity. So again, SSD approach, lateral. So a little video to show you the neck osteotomy. This is probably the most difficult operation I do around the hip on the femoral side, even today. Because a lot of times the head is stuck in the back of the neck and we don't know where the vessels are. So we're creating a, see the facial scar is here. I'm leaving that much gap between the physis and the osteotome. Head is in the back here. And the vessels are stuck in the back, so you can't go straight across with that osteotome. I don't know of any Gahn's description of this technique anywhere published, so I'm doing it, I've learned it on my own, and I'm taking small wedges of bone, right, to narrow it down before I break the posterior cortex. So here. So that's the neck, shaft, head right there. So we removed a little wedge. Retinaculum is protected. I'm close, but it's safe. So removing an anterior wedge slowly. Then now we're disconnecting the head from the posterior neck by doing, going from superior to inferior along the posterior aspect. So the osteotome is in the, between the head and the neck posteriorly. At some point you break the neck, drill a hole in the head, it's still viable. And then with the burr, I'm removing the metaphyseal bone that's on the head side. Because I stayed away from the physeal scar, so I need to get back to the physeal scar by removing that bone. If I don't, it can still kink a few tissues. So you have to look at the vascularity and adjust. You don't need to remove all of it, but whatever is required, you need to remove. And the burr works well for that. And then we fixed with 2 screws. Correction, correction. That's femoral neck osteotomy.
Very nice to see such surgery. Do you take per-operative X-ray to understand this last surgery which you do, the neck shaft angle where you put the osteotome, the curved osteotome you are going?
X-ray probably won't be that helpful. You can see things actually. Once you got enough thickness of the neck with the wedge cutting from the front, I go from the back, they're fused. The neck and head are fused in the back, right? You just need to make a plane where you don't leave too little neck and not too close to the head. So you
Exactly,
can see,
identifying the, we will have to see a number of cases with you to understand.
Vessels, you look at the vessels, the flap, as long as not risking the flap, you can go through it.
Excellent, thank you very much. Now, going ahead with the thing, we will be talking by Dr. Manoj Padman, femoral osteotomy, which are extracapsular.
Probably something that you deal with routinely for a range of pathologies, so it's not as complex and challenging as intracapsular osteotomies. So I'm not going to get into too much detail, but I'm just going to highlight a few technical principles that you need to be aware of, because all osteotomies are not identical. So why do we do that? So obviously it is one way of correcting hip deformity. If it's purely a proximal femoral deformity, an osteotomy there at that level would be more than enough. But if there is acetabular work to be done, then it is used in conjunction with intra-articular surgery. So I'm just going to bring your focus on to 5 key points. Define the problem. What is it that you're trying to correct? So it could be any of these, in terms of clinical symptoms and therefore corresponding radiological this thing as well, Some of it may not be fully correctable. Sometimes classically is a lot of these problems have ligament discrepancy, which may not be correctable with the proximal femoral osteotomy. So that's something which you may need to kind of tackle separately with lengthening or a contralateral epiphysiodesis. Underlying pathology matters because the natural history of each pathology is different. So all of them do need, so hip dislocation in cerebral palsy is different from a hip dislocation in DDH, So both are hip dislocations, the type of osteotomy, the planning, the degree of correction, the implant, all of them changes. So similarly, Coxa-Vara from a range of pathologies, again, all of them may not be, it's not one size fits all. They need a valgus osteotomy, doesn't mean that it's the same. Similarly, any sequelae of avascular insults which produce proximal femoral growth disturbance, correction, the technique of osteotomy may be the same, but there are subtle variations in terms of how you correct it and the implants that you use. So this is where planning comes in. You need to be familiar with what is normal orientation of the proximal femur in relation to the trochanter, the neck shaft angle, the medial proximal femoral angle, the level of the trochanter in terms of where it is in relation to the center of the femoral head. Implications of correcting proximally, what are the implications in terms of impact on the mechanical axis and loading of the knee. So translation is important as well. Apart from standard deformity planning, you'll need to kind of also indications for intervention. Depending on the pathology, you may have to do additional radiological measures to decide whether you need to correct it. In this case, the Hilgenreiner epiphyseal angle. So planning is important. Sometimes you may need for 3-dimensional deformity like this, monostotic fibrous dysplasia, you may need to, sometimes you may not be able to visualize it. And so as whatever is needed, you may need to take. So here 3D reconstruction we thought was helpful. Now the classical question which most people ask is what osteotomy when you talk about this thing. And so these are the things that you can do. You can do pure coronal plane varus valgus angulation in conjunction with rotation. Closing wedge and opening wedge options are there. By and large, in pediatric practice, we don't take any wedges unless the soft tissues are too tight. So we just do a transverse osteotomy, angulate as desired, unless the soft tissues are so tight which prevent you from achieving necessary correction, in which case you shorten. So we don't need to kind of plan for a closing or an opening wedge. Level of osteotomy is important because the further away you are away from the cora, you will need to translate. And so the principle of cora applies as well. So intertrochanteric versus subtrochanteric osteotomies and the type of correction. So you may need to do secondary translation. Adjunct procedures, sometimes trochanteric epiphysiodesis is necessary if you do a varus osteotomy and the trochanter is high riding to prevent further overgrowth, trochanteric epiphysiodesis. Valgus osteotomy is producing lateral uncovering and unmasking a dysplasia, you will need to do a pelvic osteotomy. And as I alluded to, underlying pathology is important. So this is from Paley's deformity correction book. You should be familiar with where the cora is. It helps you understand in terms of embryologically, the proximal femoral physis and the trochanteric physis is one continuous physis. So if you have a varus deformity, you can also explain it as a growth arrest on the medial side, continuing overgrowth on the lateral side. Okay, that's one way of explaining a varus deformity. Similarly, a valgus deformity, we saw some extreme cases of caput valgum as a post-septic sequelae. One way of explaining this is you use this analogy that this is where a growth arrest is happening and there is continued overgrowth on the medial side. It's a useful way to kind of understand it. It's by no means the only way of understanding it. So that's a magnified kind of similar this thing. In a varus deformity, you have a growth arrest here and there is continued overgrowth here. So the capital epiphysis, the proximal, and we'll discuss this when we talk about sequelae. So the femoral capital epiphysis, there is no growth happening. There is continued growth happening here. Whereas in a valgus, you have on the lateral side, there is growth arrest. And in extreme caput valgum, you would have seen that, that's where the tether is. and the medial side continues to overgrow. So therefore, when you correct it, so varus osteotomy, if you correct it at the subtrochanteric level, okay, so you are quite far away from the cora, and therefore you need to translate it. So deformity principle correction, so further away from the cora, you need to translate it, and in this case, you need to translate it laterally so that your axis is in line. Also correcting it at the subtrochanteric level has no influence on the iliopsoas, and therefore you will gain some length without producing any deformity at the hip. Whereas valgus deformity, which you see in extreme neurological cases, you correct it with a varus osteotomy at the intertrochanteric level, and that's closer to the cora. You will still need to translate it, but much lesser. So that's one way of understanding it, and we'll take you through a few cases here. So valgus osteotomy increases length, usually done at the subtrochanteric level, and you will need to do lots of translation. You may end up having no contact at all, and it's an end-to-side opposition. So there's no contact between the osteotomy surfaces, okay? And there is no tension on the psoas because it's distal to that, and therefore it doesn't produce any deformity. Varus osteotomy usually done at the intertrochanteric level. It's a little closer to the cora and less translation, and it's a medial translation. And these are important. The fourth thing is, what is the hardware that you're going to use? You need to have rigid fixation. You will, in certain situations, supplement it with spica, but you will need to have rigid fixation most of the time. Apart from situations like this, where it's a DDH, wherein you don't need any, you're not changing the angle too much. You do a derotation shortening osteotomy, and you may have a little bit of varus, but the varus correction is not so much. So you don't need a head hold in the femoral neck, so you can get away with a very simple implant which doesn't cost much as well. It's a semitubular plate. That's all you need. Whereas any other correction like this, wherein you want to correct extreme valgus into varus, you need to have hold in the femoral neck. So you need a fixed angle device to correct it, because you can try and achieve correction of almost 55 degrees to get the neck shaft angle to almost 100. So just putting a straight plate alone won't be enough. You need some sort of a fixed angle device with hold inside the femoral neck. So that's the correction that you're trying to achieve. So you have to do your planning in terms of how to get your wire across, so that where the fixed angle device goes in the femoral neck. So you calculate your angle of insertion. So in this case, we used a blade plate to take a 55-degree correction. So you make an oblique cut and remove this corner so that you can make it sit well. And so this is what you get. And here, unlike the DDH correction, you want a device which has a hold in the femoral neck. So this is an intertrochanteric osteotomy with a little bit of medial translation. So supplemented with a spica. Valgus osteotomy, and a lot of you are familiar with valgus osteotomy. We use it for femoral neck non-unions. So a few principles here. So this is actually a delayed presenting femoral neck, probably a couple of months down the line, and you can see. So when you do it at the subtrochanteric level, you need to translate it laterally. Okay? So that's important. So that your anatomic axis, the intramedullary, so if you imagine that you have to put a straight nail or a straight stem down, you want to make sure that the intramedullary canal lines up with the pyriform fossa. You need to be familiar with your implants. Not all implants are same. Both of them are 140, 150 degree plate. This is a straight plate which will allow you lateral translation. This will not allow. Okay? So it will kind of push the other way, and so you will have your axis distorted. So this is a flawed design. So you really need to be familiar with, not all valgus plates are identical. Okay, so that's another illustration to this thing. So remember, valgus osteotomy, you need to translate it laterally. So if you do not translate it laterally, this is where the shaft will end up. Okay, so that's way off. And that not only is it lined up with the pyriform fossa, it loads the knee compartment asymmetrically as well. So you need to translate it so that you can get your axis right. So extreme varus correction, like a developmental coxa vara. So the degree of translation, you can see at the end of it, you can see it is lined up. So you almost end up with end-to-side opposition. So three-dimensional corrections. This is a chronic malunited slip. So I operated probably about 8-9 years ago. He weighs about 110 kilos, massive guy. He had a significant deformity. I did not feel brave enough at that time to do any intracapsular correction. So this is what he had. This is what his deformity was. And did intertrochanteric flexion rotation valgus osteotomy, accepted that there would be secondary deformity at that level. I haven't seen him for a long while, so I don't have a follow-up beyond a year. So this is at intertrochanteric level, we're in a flexion, valgus, and derotation. So this is in 3 dimensions level. And again, because you will need some hold in the femoral neck, so you need to use adequate, appropriate implants for this. Now, in terms of, briefly touched upon, adjuncts and secondary effects, some of them are desirable. Adjuncts are, you may need to use your soft tissue releases. If you find that, because I'm not using any wedges, if the soft tissue tension is too much, don't hesitate to shorten it. Pelvic procedures, especially if you have valgus osteotomy and uncovering of the femoral head, you need to, you may disbalance the femoroacetabular orientation, and so you will need to do pelvic procedures. Trochanteric epiphysiodesis, very useful, especially in cases like Perthes. Do concurrent trochanteric, do not forget that. Do not try to club leg length discrepancy management and compromise your hip. So that may need to be tackled separately. So some of the secondary effects are desirable because when you do a valgus osteotomy, you gain in length, and so this is an illustration. You have a huge shepherd-crook deformity of the proximal femur. Underwent a subtrochanteric valgus osteotomy. And you can see that the earlier pre-op length difference has been fully corrected with just a valgus osteotomy. So some of the secondary benefits are beneficial. But there is undesirable secondary effects, which is a head covering with valgus osteotomy. Always remember that. And extreme varus correction. Sometimes you try to compromise, so you compromise by doing all of the correction on the femoral side or more correction on the femoral side instead of addressing the acetabular side in a dysplastic hip. And you can have, you can leave the patient with a huge lurch with a prominent trochanter, overriding trochanter. So in conclusion, you look at your hip deformity, what is it that you're trying to address? Look at what the pathology is, because all pathologies are not identical, even though it may be a varus coxa vara or a coxa valga, but the natural history varies. Do your planning well. All these factors are important in terms of what you try to achieve. Thank you.
Thank you very much, Dr. Manoj. Before Dr. John comes in, it was a very, very good presentation as such. Just a small question before Dr. John sets in. Sir, you can set in your laptop, sir. Any specific precaution in between the osteotomy as far as the adult or child is concerned?
No, I wouldn't think so. You would need appropriate size this thing, but apart from that, I don't think that really any problem as such.
Overcorrection can lead to any problem in the child?
So things like, because of continuing overgrowth, you may lose some of the correction, or you may have trochanteric overgrowth and things like that. That wouldn't apply in an adult. What you correct would stay corrected.
Right. Thank you, Dr. Manoj. Dr. Yeah. Dr.
Sir, Dr. Padman. Plate. So you said straight plate. So for this abduction osteotomy, usually for Powell's.
Yeah.
Some people use just, DHS.
Yeah,
and
DHS is
I
fine.
recommend that, and some double angle. So that double angle is not
Yeah.
as in the light of all this.
Yeah. So DHS has a straight side plate, so that's fine. That's not a. So double angle actually doesn't help in a subtrochanteric correction, because it's actually the angle pushes everything. Yeah. If you go further up at an intertrochanteric level, it sits at you don't need that much translation. So with true Powell's osteotomy, it may help at the intertrochanteric level because of the flare. But I don't see any specific advantage of a double angle plate as such. Certainly for a subtrochanteric valgus correction, it's not a good implant.
Okay, thank you.
So the double angle DHS is the problem.
Yeah,
Not so
well,
much the double
Dr.
angle fixed angle plate is not such a problem. Okay.
Dr.
So-
John will be talking on this in nominated osteotomy.
Okay, so I
Can I
think
request Dr. Mahesh, please come here?
the osteotomies around the hip would be either on the pelvic side, on the femoral side, and the femoral side has been already covered in detail, and we're going to talk a little bit about the acetabular osteotomies. And they can be broadly categorized into 3 groups. You have the redirectional osteotomies, in which you have the Salters, the triple, and the Gans. You have the reshaping osteotomies like the Pemberton and the Deka. And you have salvage procedures like the shelf procedures and the Chiari procedure. You can also look at how many bones are involved in the osteotomy. So, like for example, the Salters, the osteotomy goes only through a single bone. In the Sunderland is through 2 bones, while in the triple you're cutting 3 of the bones involved in the pelvis. They actually, by the time the adults, it's only 1 bone, but the fact that they come from 3 different parts, the osteotomies involve all 3 parts. So coming to Salter's osteotomy, which is one of the commonest ones which you would be doing for DDH, especially in the younger child. You can also do it for Perthes, and there are some other indications like paralytic conditions, sequelae of septic arthritis, and fixed pelvic obliquity when you want to cover the head. So basically this depends on hinging of the acetabular or the pelvic bone based on the symphysis pubis still being open, and you're cutting through the ileum, you're putting the limb in a figure of 4 position which opens out the ileum just above the acetabulum, and then you put in a graft which you've taken from the iliac crest into that area. Okay, so this is from James Hui. So it's showing a bone model, and you can see the cut which is here, which goes across here, and then as you put the figure or limb in the figure of 4 position, this opens out anteriorly, and you put in your bone graft into that area. The bone graft is taken from this part of the iliac crest, and you put it in here, and then you put in a K-wire which fixes this through the graft onto the posterior to the acetabulum. Okay, so that's the idea of the, and you get coverage. Obviously, there's more coverage anteriorly than posteriorly when you're doing this procedure. So here's an example of a 3-year, 6-month-old child, and here because you can see that the acetabulum is already very vertical by this stage, you need to do an open reduction of the hip, but you also need to do a Salter osteotomy to get coverage of the hip. As you can see here, the hip is nicely covered now, and those are the follow-ups at 10 months post-op. This is at 18 months post-op. You can see how the head is now still nicely covered. The acetabular angles are reasonable, and she went on to do well, and this is a 4-year follow-up on her. The advantages of the Salter's osteotomy is that it corrects abnormal direction, provides immediate stability of the reduction, does not alter congruity of the acetabulum, and the articular cartilage of the femoral head and the acetabulum are in contact in the functional position in weight bearing. Also, you get some gain in limb length, and the stability allows early resumption of function. Obviously, you have to keep the hip in a cast for some time, especially if you've done an open reduction at the same time. There are certain complications, like you can get redislocations, and all of us have seen this over a period of time, or the hip tends to go back. I mean, the dysplasia tends to progress, and you might get uncovering, or avascular necrosis is another problem. So the Sunderland is a double innominate osteotomy. So you have like a Salter's osteotomy on one side and a pubic osteotomy just medial to the obturator foramen, and you turn the whole thing. So this allows you more rotation of the whole fragment. And then you have the reshaping osteotomies. And here today, so the Dega and modifications of the Dega, like the Albi and the San Diego osteotomies, which are grouped together as lateral acetabuloplasties. And you have the Pemberton osteotomy. So the Pemberton osteotomy, again, the exposure is similar to the Salter's osteotomy. Your cut is just above the acetabulum, going towards the posterior side, towards the iliac, towards the greater sciatic notch, but not going all the way, and then you hinge open the front from that area, from the bone, and then you put in your graft, again taken from the iliac wing here, and put into this area. So you're not hinging on the symphysis, but at the posterior margin of your cut into the, towards the sciatic notch. So there's the bone graft put in there. Again, the bone model showing how this varies, and you're reshaping. So the anterior part of the acetabulum is brought down to get coverage, and you're changing the shape of the acetabulum. So these are reshaping acetabular osteotomies. And then you have the lateral acetabular like the Dega, etc., where you need to get a concentric reduction of the hip. You need to adequately release any soft tissue problems. You may have to do a femoral osteotomy to get the, when you get shortening of the femur to get a good reduction. And you ideally should have an open triradiate cartilage. So the surgical technique, again, the ileum is exposed as for the Salter's osteotomy, although you don't need to go across to the inner side as much. The iliac apophysis is split to the sciatic notch because you have to go down to the sciatic notch. And here you start your osteotomy about 1.5 centimeters above the acetabulum. Okay, so, and it goes all the way from the anterior inferior spine towards the sciatic notch. Okay, so all the way there. And you initially cut it with a straight osteotomy, a straight osteotome, and then you use a curved osteotomy to go down the side of the acetabulum till just below the triradiate cartilage, just before that triradiate cartilage. And then you hinge this, and this gap is you put in your bone grafts, which you're taking off from the iliac crest again, from the anterior superior spine area. And that's how you get your coverage. Okay, so here you can vary your coverage depending on the size of your grafts. Usually it's more anteriorly, less posteriorly, but this actually allows you to change the size of the bone grafts you use in different parts to improve your coverage in that part. So you can actually vary your coverage depending on the problem that you have. So again, here's an the other advantage of this is because these grafts are wedged securely into that area that you've kind of levered out. You don't need any fixation to hold this graft there, okay? Because this will automatically become stable. Again, you can use bone grafts that provide coverage, equal or more anterior coverage, as I mentioned. So I think we've covered that. So here's an example. This is a bilateral hip dislocation. Here we did this. This is the X-ray in with the spica, so you can't see the correction on the acetabular side. So we did a femoral shortening, open reduction of the hip, and a Dega osteotomy. And here, this is the follow-up before we've done on the left side. You can see how the coverage has been improved, and here's the line of the osteotomy, original osteotomy. This has been wedged open, and the bone graft has been put in there. There's also this modification of the Dega osteotomy from Paley. This is like a combination of the Dega and the Pemberton osteotomy. So you kind of make an angle here and go down at about, and open out this wedge and put in your bone grafts accordingly. So this is a combination of the Pemberton and the Dega osteotomy. And this is the Paley ilioischial limb modification of the Dega osteotomy. Finally, we come to the triple innominate osteotomy. And these are again redirectional pelvic osteotomies. They focus on restoration of the hip morphology and biomechanics. And presumption is that at normalization at early age will reduce pain, improve function, and prolong the longevity of the hip so that you delay possible THR, as was mentioned earlier. Originally described by Lecour et al. In 1965 and Hoff in 1966, modified by Steele in 1973 and Tonis in 78, before you had the periacetabular osteotomies, which was described by Gans. So these are from Alaric, where you do the ischial cut in the prone position. You must confirm that your cut is complete on the image intensifier by putting in a laminar spreader and spreading out your osteotomy. And then you do the iliac and pubic cut through an anterior ilioinguinal approach. Okay, so you do all those and then you rotate the entire fragment. So this is an interesting case. This was a child we dealt with an open reduction of the hip at an early age, and he was okay till he was about 4. By the time he was 6, that was the condition of his hip. It was interesting because he's again got this caput valgum here. And this was the time we said, okay, you need to get coverage of this head here, but he didn't come back till about 2.5 years later, and by that time, that was the condition of his hip. And we kind of were debating whether we need to do something like a Chiari or try to salvage the hip. We decided on doing a steel type osteotomy. That's the kind of correction. So we did an open reduction, shortening, varus, as well as a steel type osteotomy on him. I don't have the follow-up x-rays. The hip looks okay, but he's having pain in that hip. So I'm not sure we made the right decision in doing the steel osteotomy in this patient. Prasad, do you think a periacetabular would have done better, or you would go for a salvage here? Yeah. 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 Yeah, I think maybe salvage procedure might have been a better option here. So those were the osteotomies that we did. And then we come to the periacetabular osteotomy, which is a little closer, and Prasad's going to talk about that, so I'm not going to go into details of that. But basically, you have 3 cuts which are closer to the acetabulum, which allows you more maneuverability with that fragment, allows better correction and better coverage close to where the problem is. Finally, all of these have complications which you have to be aware of and try to avoid, starting from nerve injuries, joint penetration, AVN, non-union, stress fractures, as well as abductor weakness. So do your procedure carefully so that you do not have complications. You also have the salvage procedures like the shelf procedure and the Chiari osteotomy, which are for coverage of an incongruent joint. So once the joint is incongruent, doing any of the other osteotomies is probably not worthwhile. So you can get coverage by a shelf procedure, which is basically you take off the outer table of the acetabulum over the capsule. So you're not opening the joint up on trying to reduce it, but you just cover the head better and put in bone grafts so that this fragment, the coverage is maintained out there. And this is one option. And the other is the Chiari osteotomy, where you centralize the acetabular part and get coverage by doing an osteotomy and shifting the central part more medially so that the superior part is giving you coverage for the femoral head. So I think osteotomies are among the earliest orthopedic procedures, are still very relevant today. I think you need to plan these very carefully, and they can help to retain the natural hip joint for many years. They may also be used as salvage procedures in certain conditions. Thank you very much for the patient here.
Thank you, sir. I would like to one question. There's so many osteotomy in the pelvis for the purpose of containment of the head. So I would like to ask which osteotomy is easier to do for all of us and with less complications.
Yeah. So I think for the younger child, it is the DEGA, which is the lateral acetabuloplasty, because the big advantage is you don't have to fix that osteotomy, and it gives you coverage over the entire area. But you have to be careful about your osteotomy. The Salters was what was available earlier. We all did Salters, but most of us have shifted towards the DEGA or some modification of the DEGA today. So that is in the younger child, and in the older child, probably the periacetabular osteotomy or the steel is what you would have to do. Okay?
Thank you, Dr. John. So many osteotomies around, and still few more coming with Dr. Prasad. We really need some kind of a scoring system. I would like all of you people to come up with some scoring system where a orthopedic surgeon like us can directly count and where to go.
It's age dependent, really,
yes,
isn't it?
some scoring system. Age would also be one of the factor there. So, requesting Dr. Prasad to come up with his talk on periacetabular osteotomies.
It's easy for me, introduced my topic well. I'm going to go through the technique. I don't expect any of you to see this, listen to this talk and go and try to do a periacetabular osteotomy. It's a difficult operation. Please don't try it, right? Some cadaver dissection, some mentorship is important. A lot of potential complications. Very good operation. If I can do it, you can do it too, but learn it properly. Periosteal osteotomy was devised in Bern. Some people call it a Bernese osteotomy. Reinhold Gans was a senior person involved, but most of the work was done by Geoffrey Mast. He used to travel back and forth from Paris and Switzerland to develop this osteotomy, and Gans used to supervise him. Gans won't travel, but Mast will do all the cadaver dissection for this. So it developed in the 1980s, and I think the first publication was in the late 80s. It's considered today to be the best redirectional osteotomy of the acetabulum, most desired at least, after triradiate closure. Two reasons not to do it in younger people. One is theoretically there's a risk of triradiate damage if you do the osteotomy because it goes through the cartilage, but that's not a problem if the child is over 8 years of age. But more importantly, a younger child, it's much harder because the bone is softer, the growth plates are open, and the periosteum is thicker, so the correction actually can cause fractures. So don't do it in younger people, even if you think the triradiate is not a problem, right? It's more for mature, strong bone. The advantage is that it allows tremendous correction in any direction, right? Still leaves the piece large enough not to get AVN. Some of the Japanese osteotomies that used to go very close to the acetabulum, spherical osteotomies, give more correction than even the PAO. But the problem is the vascularity of the segment is at risk. So PAO balances between having enough blood supply, soft tissue attachment, and have good correction. So indications. Commonly, we all do it for acetabular dysplasia, but that's not it, right? You can do a reverse PAO for a protrusio acetabuli, where the sourcile cannot be resected, right? I'll show you an example. Not very common. I've did it only 3 times so far. And there is the retroverted acetabulum. You can antivert, which is like a regular PAO, but still the direction of correction is a little different, right? Contraindications. Incongruous hip, like John mentioned already, don't do a redirectional osteotomy if the hip congruity cannot be improved. Dysplasia with a flat sourcile. A rare variation is the sourcile is already flat and it's dysplastic. So you can't cover with the PAO, then you cause a negative sourcile angle. You show the example of negative sourcile angle, which is not ideal. So that's a contraindication. Even if the congruous hip, if the sourcile is small and flat, it's a contraindication for a PAO. You should do a Chiari in that case. Too much arthritis, not good. Elderly patients are better done with THR than an osteotomy. So here's a case example. One of my first few, maybe the first or second PAO I've done. Subtle dysplasia, actually dysplastic on both sides, but see the difference on the right side? Both are undercovered, but the sourcile is flat and the shunt line is not broken and no symptoms. Here shunt is broken, sourcile is upsloping, right? She's subluxating. She was 15 or 16 years old. So very small correction. If you look at that to this, maybe 10-degree correction. That makes a big difference. That's all she needed, right? 10-degree correction, flat sourcile, the sourcile is centered over the head, symptoms go away. So what's the best optimal correction, right? Every hip has its own ideal number. You don't shoot for 20 degree this and 10 degree that. You're going to optimize that hip by having a flat sourcile centered over the head. Centered over the head because if it's valga, you do a little more correction, vera, a little less correction, right? You need to tailor it. Balance the walls. You may not have enough walls to get 50 and 20 like I said, but what do you get? A little more posterior than anterior. Try to balance what's available for wall coverage. Make sure the hip is congruous and at least head 80% covered. That's minimum. Medialize the hip center. Mechanically, a hip that's medialized is better than hip that's lateralized, right? So medialization. And no impingement at the end. Check for range of motion. Again, 4 pillars. Instability, you're doing a PAO, but you make sure that the abductors are working well. Range of motion is good afterwards. And the cartilage you put on top is good. So here's a more severe dysplasia. look at the shape. This is more of a post-traumatic dysplasia. If you have a young child who gets tridated damage, this is the type of dysplasia they get. But good joint space, right? He's 25 years old, big, bulky male. Look at the amount of correction we could get, right? From here to here, about 50-degree rotation of the acetabulum. This is more of a Charcot-Marie-Tooth type of bilateral dysplasia. You need a lot of correction. So PIO is powerful, but I'm going to admit that a triple modified with Tonus 2, where the ischial cut goes above the ischial spine, is as good as this. It may not be as glamorous as the PIO, but still corrects just as good, right? And I actually convert from PIO to the triple without any hesitation if my PIO is not going very well, right? It's the same correction. The thing about pelvic discontinuity is theoretical. It's not a problem. You don't create any secondary deformity with a close enough triple compared to a PIO, right? It's easier to learn. All right. So I showed you this X-ray already, so I'm going to skip. So PIO schematic, a little bit of a. So instead of going all the way into the sciatic notch, you're cutting in front of the sciatic notch. So this is a video courtesy Venkat Das. The first time I did a live surgery ever in my life was at Ganga, and this was one of the cases. I think this is the second or maybe the first case. So not a big incision, right? Anterior Smith-Peterson interval. Even I don't know which side the head is. Orientation wise. Okay, now I'm good. I'm standing on this side, head is on the left and foot is to the right. Right, it's a right hip. I'm standing on the right of the patient. So head, foot. So it's a small incision because this is I don't know. It's live, but still we didn't make a big incision, so we can't show everything as much as you want. So anyway, what's important is you're going to the ischium from the front. So it's a blind cut. There's no real palpability with the osteotome. So you need this special osteotome angle like this to do that cut. If you don't have this osteotome, you cannot do a PIO through a single anterior incision. You need to resort to a second incision, medially or posteriorly. So this osteotome is going around the head, capsule, around the capsule, below the iliopsoas, towards the ischium in the back. It's not unsafe, right? But it's blind. Flex the hip up, iliopsoas, underneath the iliopsoas, above the capsule, you go around and you hit the ischium. So the osteotome is placed there, you can see it, below the acetabulum on the AP view. So I'm slightly lateral on the ischium. You need an angled osteotome to get to that angle, right? Then you get an oblique X-ray, iliac oblique X-ray to see how deep you're going. AP is to see how medial lateral you are on the ischium, and this oblique is to see how deep you're penetrating into the ischium. Incomplete ischial cut, just want to go 10 to 15 millimeters posterior, that's all you need. So this went far enough. Now we're exposing the pubis, pretty standard anterior approach pubis. You don't dissect any neural vessels, not the ilioinguinal. This is more of a Smith-Peterson, lateral window only, the whole time. In the pubic cut, protect the obturator neurovascular bundle, and then cut the pubis. You can use jiggly saw or an osteotome. Now we're trying to develop that the ASIS of developing submuscular tunnels on either side of the iliac crest to do the iliac cut. So that's iliac cut. Now this is a posterior column cut. That's a sciatic notch. We did this cut already. We did this cut down. Pubis is cut. So posterior column cut. Again, I'm not trying to go through the details of the operation because I don't expect anyone to go and try this after just watching this video or listening to me. It's more to show what can be done, what may interest you to go and learn more. Oh, so I skipped a step. The iliac cut is being made now after the posterior column cut. I do actually do the reverse. Gans says that's ischial cut, pubic cut, and number 3 is this. For me, this is number 4. So I did the ischial, pubic, and then the posterior column cut. And now I'm doing the iliac cut from front to back. So the primary cuts are made. You need to deepen these cuts and mobilize the acetabulum. Then the more important part is getting the correction correct, assessing the correction intra-op, make sure that you're not over-correcting or under-correcting. So we'll make sure that the cuts are all deep, complete. So acetabulum is moving now. That's the posterior column cut. Ischial cut is down below. You're trying to connect the two. So you can see the ischial cut again, you put an osteotome there just to complete it. So you can see the osteotome, iliac cut, posterior column cut, ischial cut, pubis in the front. Connect all of them and move the acetabulum. So we're using a joystick, a shank spin, to control the acetabular correction. So gently stretching out the soft tissues. I think, what happened? Oh, sorry. I didn't show the post-op final. I did get a good correction. Take it from me. Yeah, Venkat Das is my witness. Yeah, we have follow-up. Patient did well. The correction was good. All right? Thank you.
You have got 2 more papers, sir. We'll go with the relative neck lengthening and hip arthroscopy basics.
Okay.
So you can continue with it.
All right.
And one important question, sir, how many complications you have faced in this? This is such a major surgery.
Yes, PAO is complicated. The first few cases, you can expect something bad. My very first case I ever tried was not enough anterior coverage, retroversion, but luckily did fine. My second one ended up being a post-operative wound infection because it took a long time for me, but I had to give antibiotics and she did okay. Third one did really well. I think this was the third one I showed you. Fourth one, I had an intra-articular fracture that I had to correct by putting a screw and then completing it. And after that, I've been doing okay. So it took me about 4 cases to get over the learning curve, but some people say it takes 20 cases. The more you train, right? For me, when I'd start doing this, I didn't have as much chance to train. Nobody was doing it in Chicago at all, right? 0 in Chicago at that time. So a lot of things I've learned, that's not the right way to learn though. So I'll be happy to help you. Join the group, discuss the theoretical parts, and come for courses, learn, practice on cadavers. It's not complicated. It just needs more, careful training. Don't jump into it too soon. All right, relative neck lengthening. We talked about this a few times already. So we were all told that the neck shaft angle, somewhere between, right, 125 to 130, 127. I already told you the head diameter, the neck length, ideally is 1 head diameter from the center of the head to the tip of the trochanter. Anything longer than that is too long, anything shorter than this is too short, breva, longa and breva. But if you look at the actual neck function, the actual neck shaft angle, the length are not that important. What is the neck for? The neck is there to improve the range of motion. If the neck is as thick as the head, you won't have any rotations. You only get flexion extension. The neck has to be narrower to allow rotations. The second thing the neck does is give you an abductor lever arm. Put the GT and LT far away from the pelvis so they don't impinge. So if there is no impingement and the range of motion is good, who cares what the neck shaft angle is? I have cases of 90-degree neck shaft angles post-op because I made sure that the other things are not a problem because I needed that 90-degree to cover the head correctly. And I'll show you examples. So the actual neck shaft angle is not important. What the neck does, you understand, and your result should not cause any problems with impingement, right? That's what the neck is for. So what are the things RNL is used for, right? So coxa breva, too short a neck. You can either do true neck lengthening, like the Morsher or Lascombs. You've probably heard about those. I'll show you what they are. But you can do relative neck lengthening, which is a little variation that has advantages. If you have coxa vera, and you don't want to really change the head to the acetabular relationship, like I said, coxa vera with acetabular dysplasia, they're balancing quite well. I don't want to do a valgus osteotomy, but the coxa vera is causing abductor dysfunction or impingement. I can do RNL. I'll show you an example where you don't need to change the head orientation, but still take away the negative effects of the coxa vera. You have caput valgum. We showed examples already where you want to do varus, but the trochanter is already high, so you do RNL first and then do varus. I'll show you an example of that too. So starting with coxa breva. Breva is often associated with vera, not always, but often. The short neck causes neck impingement, GT impingement, and LT impingement. You can do all of those. So you do true neck lengthening. There's a double cut and triple cut. Double cut is Lascombs and triple cut is Morsher, right? Or you do relative neck lengthening. We'll discuss which one is better. So that's the Morsher. Morsher is basically both involve a cut above the lesser trochanter. Both involve a cut at the top of the neck. So this is the new neck now. In Morsher, you take a separate segment and interpose between the two, and in Lascombs, you don't take a separate segment. Bring the whole trochanter and put it there, and both lateralize the shaft so they get leg length also. You gain a centimeter to centimeter and a half of leg length, right? The disadvantage, in my opinion, with this operation is the blood supply to the head is right there. You remember Venkat Das's slides of these vessels coming to the neck and head? I don't know where this osteotome is going. They're not looking at anything. They're just blindly doing the cut. The reports don't talk about AVN rate, but I don't believe that it's zero. I think it's significant, right? They don't report AVN rates in any of the papers. The inferior cut is also close to that ligament of Wiedebrecht in the bottom, again, blood vessels. So both these cuts are very close to blood vessels, which you're blindly cutting without looking at them, right? That's my problem with it. Second thing is, to gain half an inch of leg length, do I want to really do a subtrochanteric osteotomy and put a plate on it? For half an inch leg length, would you do an osteotomy anywhere in the body to get half an inch leg length? Think about it. So RNL, the advantage of RNL, relative neck lengthening, it's not true neck lengthening. No change in the head shaft alignment. No, you don't disconnect anything with the head, neck, and the shaft along the medial calcar area. They remain the same, right? They're continuous. So you don't change the head in the acetabulum. You don't need to change the head in the acetabulum. Then why do any varus or valgus, right? So you can do RNL. So no change in head cup contact. You can change head and neck shape, abductor length and lever arm independently, and you optimize those. They're not interconnected. Each of them can be changed at will. Easy healing. For the patient, RNL is much easier to heal, right? And no plate fixation. No osteotomy on the side and no plate fixation. Disadvantages. It needs skills in SSD, safe surgical dislocation, and ability to raise the flap on the neck. Peeling that neck of the soft tissues, you need those skills. So it's difficult on the surgeon, but easy on the patient. So if you learn this technique once, it's much easier on the patient to recover from. Very, very good operation. There's a risk of instability because you're opening the capsule. So you should not have any risk factor of instability, no acetabular dysplasia, right, when you do RNL. But the one negative people say is you can't lengthen the leg. I don't want to lengthen the leg through a subtrochanteric osteotomy. I'd rather do it with a lift or a distal lengthening rather than doing a subtrochanteric osteotomy to get some length. So SSD approach, Venkat Das went through the approach. It's safer to the blood supply. You don't need to dislocate the hip completely. It's an approach only, right? For RNL, you don't need to dislocate the head. It allows comprehensive correction of femoral head, neck, every other shape, right there. The cam can be resected nicely, right? And then, but the capsulotomy can destabilize the hip, so be careful. You need to know how to develop this flap. It's tedious and meticulous dissection of the lateral retinacular flap from the GT, right? It's not as extensive as the done osteotomy flap, but you need to go far enough whether however far you need to remove the neck. So you don't need to go all around. So the anterior and posterior flaps as much as required to resect the neck. Loose capsular closure because tight capsular closure can disrupt the blood supply to the head, so you don't suture it too tight. And then advance the GT to wherever you want appropriately. So RNL, wherever there's coxa vera that I don't want to turn the head, do a valgus osteotomy, I can do valgusization with an RNL where I create a valgus appearing neck shaft angle with all the advantages without doing a neck between the osteotomy between the neck and the shaft, because the top of the neck can be removed. Here's an example. This patient has caput valgum coxa vera, but the caput valgum is not bad enough to do a varus, right? This relationship is okay. So I don't want to change this with any type of valgus osteotomy. There's a big cam, so I know that I have to open the capsule, right? And the trochanter is very high, impinging in all directions. See the big cam in the front? So did you notice that sagging rope sign in the front? Somebody asked what sagging rope sign is and how this is the deformity of the head. And you can see it coming out way down there. That's not healthy. Look at what we got. How much neck did we gain with no osteotomy on the inside? As long as the lesser trochanter is not impinging, you can get as much length as you want on the neck. Whatever valgus angle you want to create, you can create. Right? And the cam is gone. Here's a morsure. You're cutting, look at where the cut is, where the vessels can be. And look at the relative neck lengthening, where it seems like I've got a lot of neck length with no osteotomy of the neck. Are you guys following this? Right? You're getting a lot of neck length, except for LT not moving. It is as good as a morsure with no morbidity. No extra morbidity, I meant to say. Severe caput valgum. The fovea is against the sourceal, very severe, right? So this neck axis should be parallel to this perpendicular line from the physis, ideally. So we need to correct this, a 60-degree correction. This is what I did. If you look at my neck shaft angle, you may say that's about 90, 95 degrees. But look at my relation of the head to the sourceal. Good relationship there. I'm not impinging. The abductors are pulled down. My GT is underneath the plate right here. Right? So the neck shaft angle is not as important, right? As long as your other mechanics are taken care of. So why is RNL so advantageous? They can weight bear as tolerated from day one. You just need to ask them to use crutches so that the abductors are not going to be stressed, the repair, but they can weight bear as tolerated. You take anti-hip precautions to prevent instability, and range of motion can be very quick. Thank you. So I'm last talk between you and lunch, huh? Oh, okay, okay. So this hip arthroscopy. How many people here saw the arthroscopy yesterday? Anybody? Anybody? Only one person? Two? Okay. All right. That you can learn and try. So why is arthroscopy? Just like any other place, it's a lot less invasive than open procedures. It's not safe without fluoro. So don't let anybody say that I can do arthroscopy of the hip without any x-ray. Not at all safe. It's too blind and too much of a problem. Cannulated instruments are essential and make it easier. The only time I got into trouble was in a very young child. The instruments had to be so small that I tried without cannulation, and I got into trouble. I hit the femoral nerve with the instrument. So temporary neuropraxia was caused because I was overconfident and tried without cannulation. So it's a good idea to use a needle, guide wire, and cannulated instruments to do this. Traction is essential to look into the acetabulum. You cannot say that, oh, I don't need to distract to do a hip arthroscopy. If you're doing only peripheral compartment, only look at the neck, you can do without traction, but if you want to look at the head, pull it out, you need traction. And you need a 70-degree scope to look around the corner, and longer instruments are important. The regular instruments may not be long enough, right? So you can do it supine or lateral. I do it all supine. Joint distraction is for central compartment access. Central compartment is between the head and the acetabulum. Peripheral compartment is outside the labrum. You don't need traction for that. You can even look at the psoas bursa. You can even go underneath the gluteus maximus endoscopically, do gluteus medius repairs, sciatic nerve decompression, and hamstring repairs endoscopically. It's not arthroscopy anymore, it's outside endoscopy. C-arm guidance, traction is on already. This first portal is always under fluoroscopic guidance into the lateral hip. Needle just above the femoral head. Palpating the trochanter. So, on the AP view, I'm not in the hip yet. Actually, I was in the hip, I injected air into the hip for air orthogram, but I pulled it out of the hip. I'm parked over the capsule, and I'm making sure that I'm mid-lateral. If I'm anterior-posterior, the needle will be on the air shadow. If I'm lateral, the capsule will be between me and the air shadow. That's how I know that the needle is lateral. Right? If I'm lateral, what I see on AP is perfect. I'm away from the labrum, away from the head. Right? And entered deep. That's another sign that I'm lateral. So where else can we do hip arthroscopy? Little things, synovial biopsy. Any of you can try that. That's easy. You don't need traction that much. You can go into the peripheral compartment, punch biopsy of the synovium. That's okay. You want to check the cartilage status diagnostically. Look at is the hip healthy enough to do a PAO in an older person or a neck osteotomy. Or a painful total hip is a good indication to do synovial biopsy. A painful total hip, you can't really damage anything. If you bang against the neck, I think it's okay. So you can take a biopsy. Debridement, all types, loose bodies, synovitis, septic hip, great option. And you can cut the iliopsoas stenotomy. These are simple indications in my opinion, straightforward. Patient with FAI, labral damage, head, labral rim, right? Patient with chondral lesion, microfracture. I'm not saying microfracture is the right treatment, but you can do that pretty easily arthroscopically, a simple indication. Somebody else did it in DDH patient. I tried it once or twice in a baby to remove the pulvinar fat and the ligament teres. Unnecessary, but you can do it. Iliopsoas stenotomy, right? Pretty easy to cut the psoas tendon endoscopically without opening at the lesser trochanteric area. Some X-ray control. That's iliopsoas, you can see through the central compartment. If I need to cut the tendon, I can cut it quite easily. Standard indications for most hip arthroscopies: anterior FAI, anterior cam, slipped epiphysis that you want to do an osteoplasty, pincer resection anteriorly, subspine impingement, the AIS can be reached easily, labral repair and reconstruction can be done standard, and if the capsule need to be tightened, you can tighten the capsule. Cam before resection, after resection, growth plate open, younger child, right? You go medial to the growth plate to do the cam. This is what we did yesterday, right? Very similar. Establish rim trimming, the triangle yesterday people saw, labrum was repaired back, cam osteoplasty on the femoral head, open growth plate, younger child. Extended indications. What can be done after you gain some experience? You can excise piece of heterotopic ossification pretty reliably. You can do femoral neck osteotomy arthroscopically. I'm not recommending it, but it can be done. People have done femoral head fracture reduction and fixation. Established fractures, simple ones, can be actually managed by arthroscopic control, right? You can excise the femoral head if you want arthroscopically. It takes a long time. People have done triples. You can do sciatic decompression like I mentioned before. This was my first femoral neck osteotomy endoscopically. The family said they let me do this only if it's done arthroscopically. And I said, I've never done it before. Then I said, go ahead, do it, your first case. So I got my golden opportunity. So I did a done osteotomy endoscopically. Took a while to burr out all that neck and do the osteotomy. Completed, aligned, fixed with 2 screws. It went well, so I offered it to a second patient, but it didn't go that well, where the neck shortening caused it to subluxate. This girl was thin, so it didn't subluxate. The second girl was a little bigger and started subluxating. That's when I said it's not a good operation because I cannot advance the trochanter and reduce the hip adequately. So it's not a good operation to do, but it can be done. Sciatic nerve can be visualized. When you do piriformis release for a sciatic piriformis syndrome, you don't know if there are any bands elsewhere. But endoscopically, you can run all the way from top to bottom, looking at every little band and release it through 2 small incisions. It's a much less morbid release. For you to do entire sciatic release, you need a big exposure, like a total hip exposure, not a small little incision. So most of this procedure can be done with 2 small incisions. Complications, important to know complications. Iatrogenic damage is still possible. Yesterday I saw some damage to the labrum and I thought I did it. Then as I looked at it more, I couldn't have done it with 1 penetration. I went only once. There's a lot of damage in the labrum and cartilage. So it's unlikely, but I can still cause damage. Fluid extravasation is a problem. Thigh distends, abdomen distends. I reported on a pulmonary edema case, a child with pulmonary edema from fluid going to the venous system. Abdominal compartment syndrome is known. Traction injuries, pudendal palsy from the perineal post, foot neuropraxias from pulling on the leg too much, incomplete resection, over resection, right? All those are possible. Just want to show you a simple technique for somebody who wants to try. A child with septic hip, acute enough that you don't need to do too much decompression. ASIS to great trochanteric line, right? And on that, enter on that line, perpendicular to the neck. This is a needle actually. This child is like 5 months or 11 months old. The needle, look at how big the needle looks against that neck. Over the needle a wire and then the cannula went in, regular standard arthroscope. Looks as big as the neck, but there's enough room for it. And you can, this is how good you can see the hip. Wash it out thoroughly with a small incision. So if you're interested in hip arthroscopy, you can start with small procedures like this, peripheral compartment, simple procedure, and extend to more and more involved procedures. Thank you.
Thank you very much. Such an interesting session that was. All truly very difficult and interesting surgeries which we did. We'll request all from the audience any questions to be asked to our learned faculties. Yes, please.
Yeah, people are doing it. I've done it in simple fractures, and somebody from Kerala presented saying that he's putting a scope in every time after he fixes it, he looks at the reduction.
Yes, sir, this year in Neopas, Dr. Jose from, but is it in, other people do this?
No, see, most of the trauma surgeons, they can see everything they want to and then assess the reduction, right?
He was doing the next day, sir. He did the fixation, then the next day he took the patient to a
Next day?
Yes,
Oh,
sir,
I didn't get that feel, but anyway, that's unnecessary. It's unnecessary thing. If you do arthroscopy, you should be able to fix it with minimally invasive techniques, not opening up and then checking again, right? But there is a risk.
It has to be done under traction, and you're doing intrapelvic approaches on a deadliftable. He was doing just for, I saw his presentation, just for theoretical purpose he was doing to check the reduction. I was asking, is there any indication for doing it right now when we are fixing the fracture?
Yeah, when you're fixing it, obviously, right? Head fractures, simple transverse fracture that are closed already, when you put traction on, things are lining up, all you need to is lag together, and you want to just clean up some debris and see the compression, great indication. Putting a column screw, right? Putting percutaneous column screws, you got your closed reduction, is reasonably close. You just want to look inside, clean up that debris in between, and see the lag screws compressing nicely. It's a great indication. Pardon?
When it is done by some surgeon, next day of the surgery of any pelvis fixation, any uni or bicolumnar fixation, and next day he is doing arthroscopy after giving that much of traction, it may loosen his fixation also.
Yeah. I see. I don't see that as a good indication to do any of that.
So like for sciatic nerve decompression, you have said, like which portal you will prefer to go and how you decompress the extra-articular portion of the sciatic nerve. And
So you know, sciatic nerve is a posterior structure.
yeah.
One of my mid-anterior portal actually allows me to actually get into the bursa, so I don't need to make a new portal to see. But to access the, once I see the bursa in the back, anything in the buttock like this, in line with the sciatic nerve, let me go up and down. So it's not like an exact, like 4 centimeter here or 3 centimeters. Like I said yesterday, the centimeters are not important. Put a needle in. Is it in line with the sciatic nerve? Are you able to reach where you need to reach? And do a portal. If you need a second portal, go and do it. And the poke hole doesn't make a big difference. But typically, you can do the entire decompression with the anterolateral portal and a posterior buttock portal.
Any same scope which are using either in the shoulder or the knee, in the hip is the same scope or a different?
So hip is a deeper structure. So the 30 degree can be used if you're going to go peripheral first or do it in the lateral position. But if you do like what I do, supine and central compartment first with distraction, 70 degrees is a must.
Diameter is same. Diameter of the scope.
It's the same diameter, but length is extra. The scope length is not as important as shortening the bridge, so the working length of the scope is longer, right? But there are longer hip scopes now. So start off with longer hip scopes than trying to do with the knee scope.
How much long, sir?
I don't know the exact length, but it's probably at least 2 centimeters longer than the knee scope. But at the same time, for really large patients, in my hospital, we have a laparoscope.
Yeah, that's why I was
asking. This long, that can be used.
Thank you, sir.
Thank you very much. Over to, by this, we come to end of this session. I hand it over to Saurav for further.
Request Ranjit Singh sir to honor the chairpersons of this session. Please honor Amulya sir. And to honor Rakesh Chaudhary sir. We move on to the third session, which is directed towards tackling the problems of the very young hip. And for this session, I request the chairpersons to come on the stage. Dr. Santosh Kumar sir, Dr. Soman Chatterjee sir, and Dr. Rajiv Anand sir.
Pre-lunch session, session third, young hip. The first speaker, Dr. Manoj Padam, the post-Parthi and septic sequelae.
So this session will be focusing on a few specific pathologies, not the primary treatment of these pathologies, but sequelae and effects. So you may find some of the content overlapping because these are all kind of, one big basket of things. So the way I look at it is like they're all sequelae who have had a deformity of the proximal femur, which can be extra-articular or intra-articular, whatever be the underlying etiology, extra-articular or intra-articular, and consequent acetabular changes over a period of time, and eventually ending up in a common pathway of premature degenerative arthritis. Now, the common feature in all of them is that there is some form of proximal femoral growth disturbance, whether it is Perthes, whether it's post-traumatic, whether it is post-septic. And uniformly, the capital femoral epiphysis gets more severely affected than the trochanter, and the trochanteric apophysis continues to overgrow. There can be varying degrees of varus valgus and torsional deformity, as you're well aware with septic sequelae, and they will have shortening of the femoral neck, coxa breva, and varying degrees of abnormality at the femoral head-neck junction. Now, you can choose to call that as extra-articular or intra-articular, but at the head-neck junction. They'll also have deformity of the femoral head because of the avascular insult. There is deformation there. It's flattened, bilobed femoral head, which can be extruded. You can have various morphological changes on the femoral head-neck junction, cam morphology, and consequent acetabular changes, long-standing. You may even see bilobed acetabulum reciprocally articulating with the deformed femoral head. So that's the common kind of outgrowth. Radiologically, as we know, pelvic X-rays will give you all kind of information with additional views. Occasionally, you may need to get CT scan and MRI. If there is, especially in post-Perthes, sometimes you want to kind of do an arthrography to see whether there is any form of hinged abduction and things like that. So a few radiological parameters. I'm not going to touch too much about it. Look at the tip of the trochanter in relation to the center of the femoral head. It should be at the same level on a vertical plane, and on a horizontal this thing, it's one head diameter lateral, so that gives you both the vertical offset as well as the horizontal offset. So that will give you an idea of functional coxa vara as well as coxa breva. So another parameter to kind of look at is look at the medial proximal femoral angle, because that will give you a lot of these would get labeled as coxa vara. But the neck shaft angle is not too bad actually. Yes, there is an element, but there is significantly disproportionate trochanteric overgrowth. And that you can see by evaluating the medial proximal femoral angle. So what are your treatment objectives? And expanding on what Prasad talked about, the 4 pillars, you want to optimize the abductor lever arm and get the trochanter to its correct level. You want to lengthen the femoral neck, to restore the offset. Address if there is intra-articular pathologies causing, impingement or lack of congruency, you need to address that. Correct the LLD if possible. That sometimes clubbing them with correcting the hip biomechanics may not work out, and acetabular procedures as needed. So in Perthes disease, because we are talking only about the stage 4. So I'm not going to talk about the containment and things like that, only in the fully healed stage. And sometimes you may have to allow the healing process to be completed before addressing the sequelae. So the consequences are all of these, which we touched upon: acetabular dysplasia and misshapen, even though Perthes primarily is not affecting the acetabulum, and you can have combined consequences as well. So your options are, osteoplasty. A simple osteoplasty may be enough. Neck lengthening, relative or true. Head reduction, osteotomy. All of this has been touched upon. Or a simple distal trochanteric transfer, which has fallen out of favor, which used to be done routinely earlier, but not so much these days. So again, in terms of trying to kind of formulate a plan, look at what is the pathology that you're addressing. Is it extra-articular, intra-articular, combined, and things like that. So if it is purely extra-articular, you can get away with a true neck lengthening or a varus valgus osteotomy or a torsional correction. Most of the time, it's more than that. It's either there is an element of intra-articular or a combined pathology, and so you need much more powerful tools which have been already covered. So I'll take you through a comparison table and followed by a few cases. So a simple trochanteric transfer brings the trochanter down, restores the lever arm, and restores any impingement which the trochanter may be causing, but does not address anything to the intra-articular problem and does not do anything to the leg length discrepancy as well. And moreover, it's a blind procedure. You really do not know where you're cutting through. True neck lengthening addresses the leg length as well in addition to that, but does not allow you any intra-articular. So I really don't see any benefit with these true neck lengthening procedures. Relative neck lengthening, on the other hand, is a much more versatile tool, but does not do anything to the length, which will have to be tackled at a later stage. So a few cases. So this is a post-infective sequelae who was primarily treated elsewhere and presented much later. You can see all the problems here. And yeah, that's the lateral view. So in terms of what we wanted to kind of address, we wanted to have access to the intra-articular pathology, see whether we could kind of do a head reduction if possible, but certainly address the coxa vara as well as the bump on the laterally extruded bump. But we ended up, because the head was so misshapen and I could not get my orientation in terms of how to do a head reduction on this, we just went ahead with the relative neck lengthening, brought the trochanter down and optimized the lever arm. And you can see, and removed the laterally extruded bump. That's him on short-term follow-up. You can see that it is still misshapen, but that is, his functioning was tremendously improved because the relative neck lengthening component, bringing the trochanter down, is a very powerful tool in terms of addressing the hip symptoms. And there is incongruous congruency here. It's not perfect, reciprocally congruent. That's him almost a year and a half down the line, and I do have long-term follow-up this. There is some bit of overgrowth of that lateral corner still, but he's not having any symptoms related to that. His gait is much more normal, and this boy went on to join medical school. Recently, when he joined medical school, he came back to kind of, thank me for the procedure. That's almost about 6 years post-op, and I do have some functional videos of his. That's his functional status despite his x-rays being like that. Yeah? He has good range of flexion internal rotation motion. He can sit cross-legged. That's him walking. Yeah, despite this thing. So you can address some of the problems there. You may not be able to get a perfectly spherical femoral head articulating with the acetabulum, but improving bring the trochanter down, improving the lever arm, relieving the impingement can get you reasonably lasting functional results with this. So this is again a post-septic sequelae here. Neonatal septic arthritis, you can see all components of deformity here: caput valgum, torsional abnormality, increased anteversion with a large anterior bump. Okay, and he had pretty much nil flexion internal rotation. So in this case again, a relative neck lengthening, a proximal femoral varus osteotomy, excision of the anterior bump to optimize all 4 pillars of hip function. That's him 12 months down the line. He had significant leg length discrepancy, and we didn't do anything about it until he came for implant removal when he underwent a contralateral distal femoral epiphysiodesis. This is a post-traumatic AVN. Again, you know, a common pathway, whatever be the sequelae, they have an element of proximal femoral deformity as well as deformation of the femoral head. Underwent close reduction and fixation, unfortunately went on to do AVN, went on to have AVN, significantly symptomatic. An attempt was made to treat it like Perthes with an adductor release and Petri cast, but these behaved completely differently, and so it won't work. So that's his fluoro images, and as you can see, Shenton's is disrupted. There's a central area of necrosis, which is right under the sourcil, an extruded lateral head, which is relatively healthy. Yeah, so the sourcil is sitting directly over, the necrotic segment is sitting directly under the sourcil, and you want to get that lateral head, relatively healthy head, under the sourcil. You can see in terms of the horizontal offset, there is reduced horizontal offset, there is proximal overriding, so coxa vara and coxa breva. Yeah, so neck shaft angle is reasonably okay, but he still has functional coxa vara because of the trochanteric overriding. So all of these things have to be addressed. Okay. In addition to that, unlike a lot of other this thing, because it is a short duration history, he has significant stiffness. You can see how much the abduction is reduced. Okay, so what you really want to do, if I can illustrate it in graphical this thing, you want to get that central necrotic segment underneath. You can do it with the varus osteotomy. See where the trochanter ends up as, you know. The amount of varus needed, you'll probably need about 30-40 degrees of varus to get it under. Okay, the trochanter is going to be down, really up. So you have to have an approach to this so that you can distalize the trochanter as well. Okay, so this is possible through a safe surgical dislocation approach and extended retinacular flap and relative neck lengthening. Okay, so I'm not going to repeat all that. I think you had a lecture with Prasad, and I think further cases will also show the same thing. So that's him. That's what we did. In hindsight, I probably should have got a little bit more varus. Okay, in this X-ray, it looks as if the lateral head is healthy, articular cartilage is sitting under the sourcil. But subsequent follow-up, I thought, you know, I should have probably got it in a little bit more varus. So he's about a year down the line. And I think I have his last follow-up X-rays. Yeah, so this is at 6 months down the line, and we have corrected what we set out to correct. You have restored the center. I wanted the necrotic segment to be a little bit more medially than this. There is still some extrusion, but he's symptom-free. His offset is restored. Trochanter has come down. His gait is remarkably better. Stiffness is corrected. Not 100% normal. He still has some amount of restriction. As you can see that the hip pelvis is rotating when he tries to abduct. Reasonably congruent, and that's his latest follow-up. He's about 10 months down the line. Okay, the lateral pillar should have been a little bit more this thing, so I should have been a little bit more aggressive in varus. But what you need to remember is, in terms of concepts, safe surgical dislocation and relative neck lengthening addresses a lot of these problems. So Prasad has talked about this. I fully agree with this concept. It's something that you need to remember. Thank you.
Ask questions for this session or afterwards? We can ask. Any questions from the audience? Dr. Manoj, my question is, you are doing these operations in a younger or adolescent patients. What precautions should we take that ultimately you have to go for THR and replacement arthroplasties? What precaution you have to take to make the for the arthroplasty surgeon?
Yeah. So I think any arthroplasty surgeon, you don't want multiple surgeries distorting anatomic field. There's no doubt about it. I don't think they are very concerned about acetabular procedure. Anything which improves acetabular bone stock is, I think what upsets arthroplasty surgeons mostly if there is a deformation on the femoral side. If you do complex osteotomy, translation and things like that, that's what upsets them more. So in relative neck lengthening, there is hardly any hardware. You're not distorting the proximal femur, you're bringing the trochanter down. So I don't think they should have any problems as such.
What about soft tissue balancing? Because that's also important in arthroplasty.
So again here, when I'm getting the abductor down to its level, and lateralized. I think I'm actually restoring the abductor tension much better.
You are helping them in the future surgery.
Yeah, I think
Thank
I
you.
think I should ask them some commission now.
Any more questions from the audience for this session? No. Okay. So next question is next speaker is Venkat Das. Tom Smith, reconstructive options.
Okay. Good afternoon. So there is going to be some overlap of concepts again, and the idea is to drive home the same concepts again and again, so that it is difficult to grasp everything in one go. In this talk again there will be the overlap of concepts what Dr. Prasad and Manoj have discussed previously. So if you look at the sequelae of post-septic hip, there are a lot of classifications which have been described. It is not essential to know them by heart when it comes to management, because the most important thing which decides what you are going to do in a particular child is the presence of a capital femoral epiphysis. If you have the capital femoral epiphysis, then the principle is to restore the anatomy and mechanics, and if it is absent, the hip is relatively stable in a younger child, you are just going to observe it, and if it is unstable, the options are only trochanteric arthroplasty or a pelvic support osteotomy. You also have to take into consideration the age of the child at which he is presenting, and also the status of the cartilage while deciding on the management. So let us look at the restoration of anatomy and mechanics when there is capital femoral epiphysis. There can be three different situations. One is subluxed hip or a dislocated hip, where you will have to put the hip back inside, add on varus or acetabuloplasty as needed. The second situation is if there is a coxa vara or pseudoarthrosis, it needs a valgus osteotomy with or without trochanteric epiphysiodesis. And the third situation is a big head or a short neck and trochanteric overgrowth, which will need head reduction or neck lengthening or a combination of procedures. So this will be more like a case-based learning. And let us start with this 2-year-old child who presented with the post-septic dislocation. He had neonatal sepsis of the hip joint. And so I decided to do an open reduction, and so this was one of our earlier cases. So where I used to use KYS to hold the hip. Nowadays I don't, no more I practice the same. So this is after reduction and a spike application. At 3 months follow-up, the hip is looking okay. But you have to remember that as the child grows, these hips are prone for problems again. So they can have recurrent dysplasia and subluxation. This is at 1 year follow-up. So I had to go back inside and do a varus derotation osteotomy with the Pemberton 2. It's a reshaping acetabuloplasty. And that's a 6 months follow-up and 1.5 years follow-up. The child is doing well and never came for follow-up after that. And this was done about 8-9 years ago. And after 1.5 years, the child never came for follow-up. The second situation is coxa vara or pseudoarthrosis. This also can happen after a septic insult to the hip joint in a child. This is a 4-year-old child. He is having coxa vara. We do not know whether there is pseudoarthrosis unless you take traction films. This is the MRI of the child, which shows a decent head in place. And we decided to do a valgus osteotomy with a pediatric hip plate. And you can see that arthrogram lines out the acetabular cartilage well here. And we felt that there is enough cartilage and the child did not need an acetabular procedure. Probably it would have helped. This is a 1 year follow-up. Again, you have to remember that these children, younger children less than 6 years or 4 years, whenever you do a valgus osteotomy, they tend to recur. And you must be prepared and counsel the parents to redo osteotomies as they grow up. This is at 2 years. Again, there is recurrence of coxa vara. We have counseled the child for revision surgery and they are yet to come. The third situation is where you have coxa magna or breva and trochanteric overgrowth, where you can have multiple of options. And basically, it again all boils down to the 4-pillar concept. So this is a 10-year-old boy who presented with a painless limb, and his gait was progressively worsening. And if you look at the X-ray, there is he's also having a 5 centimeter shortening of the femur. And if you analyze this X-ray, this is coxa vara, and there is a short neck which is coxa breva, and the head is also small, which is also called as coxa parva, and there is high riding trochanter, and on to this there is femoral shortening as well. So as Manoj said previously, we don't combine lengthening procedures along with hip optimization. So the neck shaft angle here is 105 degrees. I'm going to touch upon neck lengthening procedures again, which Dr. Prasad discussed very well in his technique session. So these are all the various osteotomies which is described. One is Wagner's osteotomy, where you make parallel cuts. The cuts are perpendicular to the shaft of the femur, and then you valgize the femoral head and distalize the trochanter. This is Wagner's neck lengthening osteotomy. Then the Mosher's osteotomy, where 3 cuts are made, and this fragment is brought laterally, and it is fixed. The modification of Mosher is Lascombe's, where the 3 cuts are reduced to 2 cuts. These cuts are parallel to each other in line with the neck, and he brought the entire fragment laterally and then fixed it. And then came the relative neck lengthening procedure, which was described by Professor Gans, which was published in 2015, which is done through a safe surgical dislocation procedure, taking care not to disturb the vascularity of the femoral head. So these are the various neck lengthening procedures, and one might be, when to choose what procedure is always a question. So if you look at the Wagner's procedure, it lengthens the abductor lever arm, increases the neck length, and also increases the neck shaft angle. So it changes the orientation of the femoral head cartilage to the acetabulum cartilage, and it actually rotates the femoral head. So if you have a incongruously congruous hip, so this is something which you do not want to do. When you don't want to change the relationship between the femoral head and the acetabulum, Wagner's is not a good idea. Mosher's and Lascombe's, there is no change in neck shaft angle, but it lengthens the abductor lever arm as well as the neck length. And relative neck lengthening, again there is no change in neck shaft angle. So again, this patient was done many years back. We attempted to do a Mosher's osteotomy. This is the only case which I have done Mosher's. I tried to use a distal femur LCP to fix it, and this is at 8 weeks. It healed well, and at 4 years the hip was looking decent, but the trochanter was still not at the ideal place where we wanted to be. At 8 years follow-up, he is doing well, and you can see that nature always tries to compensate. He had 5 centimeter shortening when he came, but he had over lengthening of the femur on the left side, and is left with 2 centimeters discrepancy, which is not clinically bothering him. So he is skeletally mature and he is happy with the way he is functioning. This is another child who is 8 years. This was operated elsewhere. The child had probably a valgus osteotomy, and then 10 years down the line she came with a symptomatic right hip where she had lurch and pain, and she is having a coxa vara with a high riding trochanter, and this is you can see that the neck shaft angle is 127. It is normal here. So the problem here is coxa brava and high riding trochanter, and this is a very ideal case for a relative neck lengthening, and that was what was done for this patient, and she did well at 2 years follow-up. Yet another case which is similar to what Dr. Prasad showed, a 13-year-old girl with a post-septic sequelae. You can see, can somebody tell what are the findings in these x-rays? So just to reinforce the facts, can somebody volunteer to read the x-ray, what are all there? I know that we are before lunch. High riding trochanter, yes. Coxa brava. Smaller head, we can't really comment, because if you see in the frog leg lateral view, the head looks of the same size, if not bigger, on the left side. What about the fovea? Yeah, so there is fovea alta and there is caput valgum as well. So these are all the problems here, and the plan was to do a relative neck lengthening which will address coxa brava and the high riding trochanter, and the varus which will correct the coxa valga and the fovea alta. So that was what was done. So through a safe surgical dislocation approach, we did the relative neck lengthening and the varus osteotomy, and that is at 6 weeks follow-up and 3 months follow-up. She has not come for follow-up after this. That is a big problem with our patients. So thank you for the kind attention. So this is in summary about how we deal. I have not covered pelvic support osteotomy and trochanteric arthroplasty because this was primarily a CME to focus on hip preservation procedures.
Thank you so much for your nice presentation, sir. Any question from the audience? So in few of the cases, you do the varus osteotomy, but you didn't address the trochanter coming down. So by doing the neck lengthening, so are you happy to
So
leave the
whenever
trochanter as
there is
well high.
whenever we do varus osteotomy and if the greater trochanter is going above the center of the femur, it is always necessary to bring it down, sir.
Yeah.
So in relative neck lengthening, we are not doing varus, we are just bringing the trochanter down.
In few of the cases, you didn't bring the trochanter down, I think.
So whenever you are doing varus osteotomy, if trochanter is going higher, you have to combine both.
Both.
Yeah, in closer to skeletally mature patients. For example, if you are doing a varus osteotomy for a Perthes disease at 7-8 years old, we are not going to think about displacing the trochanter where we are doing a trochanteric epiphysiodesis which will prevent the trochanteric overgrowth. But if you are doing the varus osteotomy in a 12-year-old child, so you will be left with a permanent limp if you do not bring the trochanter down.
Yeah.
That's a problem.
So you combine those in
Yeah.
each and every case. You know?
Yeah.
Right.
That's what we meant. It will be easier for the total hip replacement later on as well.
Yeah, right. Thank you. Thank you so much, sir. So the Manoj Padman is Dr. Manoj Padman, and he'll be talking on failed DDH, I hope.
Yeah.
Yeah, thank you, sir.
Cases and experience of this for whatever reason, but there is not a lot written in terms of why it fails. So it's not unusual. This is done elsewhere, and you can see that the surgeon has tried to salvage it by bracing it, but clearly it's failed. The hip is out. Yeah. So unfortunately, you don't have access to primary X-rays, and so it's impossible to say what happened, why it failed on this snapshot. It's failed. Yeah. So if you try to kind of analyze what are the reasons for failure, the first thing is, of course, you haven't failed, you haven't been able to achieve a primary congruent reduction. That's like what you call your day one failure, yeah, because you haven't achieved it, you haven't been able to. That's a congruent reduction, a top picture. Now, that can be because of your errors in interpretation. Sometimes, you're not able to see the femoral head fully. There is a lot of unossified acetabular cartilage, and usually it happens with close reduction and arthrogram. You're not able to interpret. So you need to be comfortable doing that. So you need to be able to kind of do a good quality arthrogram. If you're doing DDH surgery, you need to be able to see where the acetabular cartilage is, not just rely only on the bony acetabular index. You can see that, the thick unossified acetabular cartilage here, and if you look at it, there is so much here. If you look at just the bony, this thing, you might think that there's a high AI, high acetabular index, okay? So that is your interpretation. So there can be technical issues as well in terms of what surgical approach that you choose, or you have not been able to kind of adequately visualize and tackle all the obstacles to reduction. That's a very common scenario in those who are not doing these approaches or not doing these cases routinely enough, that they have not gone far enough, medial enough. So this is the foot end, that's the head end. You need to make sure one of the big obstacles is the iliopsoas. You need to be able to see it. This is the head end, that's the foot end. That's the iliopsoas tendon. You need to visualize it. You have to divide it to get sufficiently medial enough. If you do a capsulotomy before you have tackled the iliopsoas, you will be fooled and reducing the femoral head into the pseudoacetabulum. That's the hypertrophied ligamentum teres. These are all well-known obstacles to reduction. So they are as all of you know, there are extra-articular obstacles to reduction and intra-articular obstacles to reduction. These need to be addressed. So this is a technical failure if you don't address them, and this again is almost like a day one failure. So now sometimes we stretch the indications where we think we can get away with an open reduction even though the soft tissue tensions are like too much, and you do not judiciously use your adjuvant procedures. You've forgotten to do an adductor tenotomy, you've not kind of reduced it into a good safe zone. And if there is adequate soft tissue tightness, if there is inadequate soft tissue relaxation, it's too tight, you have not kind of taken the extra step. So you're stretching the indications of what you can do with just an open reduction. Okay, so again, you haven't been able to achieve a primary congruent reduction. So it's not something which has happened over time. So that is one set of patients. So the amount of femoral shortening is substantial. Even though the femoral head is seated in the acetabulum, when you divide it, you can see that degree of overriding, that's soft tissue tension which you have to shorten. Okay, so it is not just varus. It is primarily a derotation, shortening osteotomy, plus minus varus as needed. So that's your day one failures wherein you haven't achieved a primary congruent reduction. The second situation is when you have not been able to, you have achieved it, but you've not been able to maintain a congruent reduction. Okay, so you've got it congruently seated, so you have not paid attention to capsulorrhaphy in terms of securely holding it. You made some mistakes in putting, you have not molded your spica well, you left it to your junior to do it. Okay, and your post-op imaging, you've not been able to interpret it well, and this is where axial imaging plays a role. So, sometimes you have spica and plaster and all that you can see with an X-ray is a spicogram. You can't see where the head is, so you need axial imaging. Okay, so this is a simple, it takes a couple of cuts of CT through the acetabulum, not a lot of radiation, and you can clearly see that the femoral head is seated very well in the acetabulum. So using axial imaging to see that you have achieved what you set out to achieve is important. Use of K-wire to maintain reduction. In primary DDH surgery, in my opinion, I don't think there is any role because you have not achieved a satisfactory congruent reduction with adequate soft tissue tension. That's when you have to rely on K-wires and things like that. So I would not kind of justify that for primary DDH surgery. Okay, so if you are having to put a K-wire to hold the hip in, there's something going wrong. Okay, so here is a case, 2.5-year-old at 11 months. Now that is a flawed management, close reduction in K-wire fixation. This is not a fracture. There are clearly obstacles to reduction you're not been able to achieve. So if I see somebody who's planned this and done this, I would have concerns about what the outcome is going to be. Here you can see it's sublux, the acetabulum is almost vertical. So child was taken to the OT, evaluated under anesthesia with an arthrogram. You could find that you could seat it congruently, medialize it sufficiently. All that the child needed was a Degas acetabuloplasthy. Okay, we didn't have to open the hip. And that's him further down the line, 2 years post-op. So if you're having to use a K-wire to hold your reduction, for occasionally, yes, in post-septic scenarios or in revision surgery, there may be a case, But for primary DDH surgery, in my practice, I don't see any role for, and that's probably the consensus for most pediatric orthopedic surgeons. That's him further down the line. You can see some amount of proximal femoral growth arrest. He's going into some amount of valgus. To keep an eye on this, I don't think it needs any intervention at this stage. So the third scenario wherein you see is, you've got all these corrected in the early phases, and for whatever reason, further down the line, post-spica removal or within the first 6 months, you see some instability. And that's usually, in my opinion, it is due to your error in your initial interpretation. And I'll illustrate with some cases. So here is a 2.5-year-old, underwent open reduction femoral and pelvic. So this is what we got with an axial imaging. Okay, so yeah, you can see that the spica is well molded. I put the spica myself. Was it congruent enough? It's sitting on the rim. Do you think it'll sit in? And it's almost sometimes a bitter pill to swallow, isn't it? Next day you see, after all this 4 hours work and it's not sitting well. And you think that it might get away with that. So that's an error in interpretation there, that this is not a congruent sitting. You can see that it is, sitting on the rim of the posterior, this thing. But I did it myself. I molded it and I thought I'll get away with that. But unfortunately, I didn't. This is further down the line. So even though it's a delayed presentation and you are confirming that it is out, but the error has happened much before. Okay, so we wait for the stiffness to settle down. Fortunately, the patient stayed on with me, went in, re-reduced it, did a revision procedure, and that's her further down the line. 3 years post-op, she's doing very well, thankfully, and almost about 4 years after the revision surgery. So that's your error in interpretation. You can have graft resorption. I think Dr. John alluded to it. And, I don't have any real explanation for it, but probably it's not a stable environment, and that's why probably the graft is getting resorbed. That's my guess. Here is a 3-year-old who underwent the full procedure. And you can see 1 year down the line when it came for implant removal, you can see that acetabulum is still dysplastic, even though there was a wedge of graft doing the Dega. So occasionally that gets resorbed. And sometimes over time, they end up having problems related to that. She subsequently needed a triple innominate osteotomy to correct this. So that is a delayed kind of this thing, but the error, I think, again, is failure happened much earlier. So you have persistent instability as well. Sometimes you know, and what is the solution to that? You know, if they have lax in top, whether you need to brace them for prolonged duration or you need to prolong your immobilization. I don't have any answers to that, but there are certain cases which kind of confuse you. Here is one which is a bilateral DDH, underwent sequential reduction. I don't leave a long gap between the two sides. So the right side was done first. You can see that the axial imaging is satisfactory. And then on the left side, you can see nobody would kind of criticize this reduction. That's him at the time of spica removal, 8 weeks. But over a period of time, you know, you can see when he came later, it started to sublux, you know, even though the original this thing is. Now, I don't have an answer as to what is the situation, whether these are the cases where you may need to kind of extend your immobilization, put the brace for longer. I do not know the answer to that. We took him back to the OT. On the right side in evaluation, you could find that it's sitting very well. On the left side, you can clearly see that there is instability. Yeah? Okay, but you could seat it in. And all that we did at that stage was did an adductor tenotomy, got it into a safe zone, and seated it well. I don't have long-term follow-up with this, but for the short term at least, he seemed to do well. So these are the usual reasons that we see why failures happen in DDH. Multifactorial. It needs to be all of them. If you are tackling them during revision surgery, you need to identify those factors and address them. Unfortunately, outcomes after revision are not as good as primary surgery, so ideally you want to get it right the first time and need for long-term follow-up. And I'll come back to the original case, what I mean by long-term follow-up.